Hmm. Okay, hello everybody. I'm Dr. Jannat Akter Riva. I welcome you all to the first session on infectious disease. And infectious disease is considered one of the most important. It's a major branch basically for MRCP Part 1 examination. You can expect around 12 to 15 questions. In general, 14 questions come from these major parts. And this can be scattered across the Part A and Part B. And without further ado, I would like to welcome one of the new students, Mr. Dr. Muhammad Khaja. Shirajuddin from Saudi Arabia, who will be joining us today on our class. So I welcome you, and I hope everybody on online and offline, you will be able to enjoy my lecture. So I have an additional degree in infectious disease, which is why I personally love taking classes on infectious disease. I did my master's from University College London, and my master's was on applied infectious disease epidemiology, and that's why I was personally interested to take this class for you people. So first of, we will actually discuss about we will start with the very beginning, that is the protozoal infection, and the syphilis, that is the treponemal infection. We will go through it first. So syphilis, it's a, sorry, why is it not working? Okay. So syphilis, first of all, this is a very common sexually transmitted infection. We know it all. And by sexually transmitted, it can be passed from one person to another via the act of sexual intercourse, particularly if it is unprotected. So it is caused by the spirochete, Treponema pallidum. Infection is characterized by, so there are 3 stages of syphilis. One is primary, and the second one is secondary, and finally tertiary stage. So incubation period actually differs from one stage to another. Primary infections usually tend to occur within 1 week to 2 weeks, and then secondary and tertiary stages can develop later on. So 90-day period is actually, it's basically the period of latency, and usually after several months, the tertiary stage, even after years, the tertiary stage can develop. So primary feature chancre, this is particularly important because sometimes some true and false statement can come. So they can change painless to painful, and they can make you rethink that, okay, whether this is a false statement or not. So remember chancre, it's a painless ulcer, but chancroid, which is caused by Haemophilus ducrei, it's a different type of infection which causes genital ulcer, but that's painful, okay? So be very mindful about this. The primary feature is chancre. This is painless ulcer at the site of sexual contact. So in case of female, it typically occurs around the vulvovaginal area or right around the vaginal opening area, and around the pelvic or the perineal area. And in case of male, it commonly takes place on the dorsum surface of the penis along the shaft. So another feature is local non-tender. So these are both non-painful or painless. So basically painless ulcer and non-tender lymphadenopathy, and often primary feature as the chancre is not seen. However, if it is present, then it can involve the cervix, which can be seen by doing parvaginal, maybe parvaginal examination can be very painful for the patient. Not painful, parvaginal, we use that, what is that? Colposcopy, right? Colposcopic examination can reveal the cervical opening, and it can show the painless ulcer site. So the secondary features, it occurs typically around after 6 to 10 weeks. If you forget the cutoff margin, just remember occurs after several weeks. And tertiary features usually takes months to years. So secondary features include some general constitutional symptom, for example, fever, lymphadenopathy, some rashes, particularly involving the palms and the sole, and some characteristic snail track ulcer, buccal snail track. So if you can Google it, I'll show you. The reason why I try to show these, pictures is because so that it stays, it gets imprinted in your brain. So as you can see in this patient's mouth, I think this one is a bit more suggestive. So it looks like a snake has, a snail has rolled out through this area and left a track. So this is known as the snail track ulcer, buccal along the buccal mucosa. This is a characteristic of secondary syphilis feature. And condylomata lata, this is another type of skin rash that is particularly can involve the mucocutaneous membranes. Tertiary features are gamma. This is a characteristic granuloma formation, and it can involve the cardiac and the heart and the brain. So in the heart, it can cause aortic regurgitation or aortic aneurysm, thereby producing early diastolic murmur in the new aortic area, something that you will go through during the cardiology session, like what are the different characteristic murmur features. But in my PACES, I think, not my PACES, one of my colleagues' PACES exam, which is the final part of MRCP exam, one of the examiners asked, like, the patient had aortic regurgitation. So one of the examiners asked him that, can you recall in this young patient without any infective endocarditis or any rheumatic fever, can you think of any other infection that can cause this type of presentation? So he was a bit at a loss. He was thinking whether this is a case of collagen vascular disease or whether this is a case of, sometimes some prosthetic valve failure can lead to aortic regurgitation, Marfan syndrome, then collagen disorders, they can produce aortic regurgitation. So he was a bit confused. He could not remember the term syphilis that time. So they were looking for the term actually syphilis. It's very common among the young individuals, in particularly in the UK, US area. So they wanted to know about the culprit infection behind it. General paralysis of the insane, or GPI, usually it presents with upper motor neuron type of features. It has a very characteristic similar finding to multiple sclerosis clinical feature. You have gone through in the neurology multiple sclerosis, right? So multiple sclerosis patient presentation can very much mimic the general paralysis of the insane. Tabes dorsalis, it particularly involves the peripheral nerves of the dorsal column, thereby producing the lower motor neuron type of sign. Features of congenital syphilis. So if a mother is affected with syphilis, and it can be passed through transplacental route, and in the baby, particularly in the early trimester, in the first and second trimester, it can cause some congenital anomalies such as blunted upper incisor teeth, keratitis, saber shins, which is a saddle type of anomaly along the shin bone, saddle nose, which means depressed nasal bridge, and deafness. So this is usually sensory neural deafness. Just a sec. No, just 1 minute. Okay, so features of congenital syphilis, they might give you questions like which of the following feature is not a feature of congenital syphilis, okay? So for example, they can change the upper incisor teeth to maybe canine teeth, or maybe instead of upper, they can put you lower incisor teeth. Instead of keratitis, they might put options like uveitis. Instead of saber shin, they can give you pes cavus deformity. Instead of the saddle nose, they can give you maybe nasal ulcer, or instead of sensory neural deafness, they can give you conductive deafness. So you have to be very mindful, okay? So I think in one of the diets in part 1 examination, this question came, which one is not the feature of congenital syphilis? So syphilis investigation is basically, there are two types. One is VDRL and the other one is TPHA, right? VDRL is the non-specific test and TPHA is the specific one. So cardiolipin, this is the another name for VDRL test. And cardiolipin test this is not specific. That's what they're trying to show. However, this is a sensitive test. Syphilis infection leads to production of the non-specific antibody that react to cardiolipin. Examples include VDRL and RPR. VDRL is basically stands for the Venereal Disease Research Laboratory, and RPR is Rapid Plasma Reagent Test. This is insensitive in late syphilis. Can you please write down neurosyphilis in the bracket? In neurosyphilis patient, VDRL will not be positive. And it becomes negative after treatment. So after treating a patient with syphilis, if you want to monitor whether the patient is having any relapse or recurrence, VDRL is the test you should do, because in TPHA, once it stays positive, it will stay positive for lifelong. So there is no prognostic value of TPHA test. It does provide diagnostic value, but there is no prognostic value for the TPHA. So it remains positive after treatment. As you can see, treponema specific antibody test and some false positive cardiolipin. So as this is a test where the syphilis antigen cross-reacts with the cardiolipin antibody, there are certain other conditions where this cross-reactivity can take place and mimic the syphilis symptoms, or not symptom, mimic the syphilis positive just by lab parameter wise. So one of the causes is pregnancy. During pregnancy, because of the immunosuppression, This autoantibodies can cross-react with the cardiolipin, thereby causing false positive cardiolipin test. SLE and antiphospholipid syndrome, the main culprit is the anti-cardiolipin antibody, which is why it can become false positive. And the others are TB, leprosy, malaria, HIV, blah, blah, blah. But SLE antiphospholipid is the main important one for false positive cardiolipin test. Okay, so question number 2, which one of the following tests is most likely to remain positive in a patient with syphilis despite treatment? Which one? Which test remains positive even after treatment?
E, option E.
Yes, very good. So once it is positive, it stays positive for lifelong. All right, next up is, let's go through, okay, I accidentally showed the number 4. Okay, give me this one answer. Question number 5. Following is the least recognized as a cause of false positive VDRL test. Yes, very good. Oral contraceptive pill, right? Because all the other can cause false positive VDRL. Okay. So treatment of syphilis is, management is basically IV antibiotic that is in the form of benzyl penicillin. Alternative, if a patient has penicillin allergy or cephalosporin allergy, in that case, we can go for doxycycline. Jarisch-Herxheimer reaction is sometimes seen after giving treatment. So after giving treatment, patient, the treponema or the spirochete, they die and they release certain toxins. And these toxins can cause some reactionary changes in the body in the form of fever, rash, and tachycardia or increased heart rate. This is known as the Jarisch-Herxheimer reaction. So leptospirosis, this is an internist favorite topic in any patient with jaundice and retinal or subconjunctival hemorrhage. And if the patient has some form of like low socioeconomic background and works in the sewage work, works as a sewage worker or works in dirty contaminated water source, then leptospirosis or Weil's disease is certainly made one of the top differentials. So we'll go through, this is another name, this is known as Weil's disease. Leptospirosis commonly seen in questions referring to sewage workers. So you see, like occupational history is one of the important factors here. Farmers, vets, or people who work in abattoir. So this is another like water reservoir type of occupation. It's caused by the spirochete Leptospira interrogans. And if you forget about the whole scientific name, it's fine because this is not MBBS level anymore. So they might not give you questions like, tell us the positive or the causative organism behind leptospirosis. Not questions like this will not come in the MRCP part 1. Rather, they might give you like a stem showing all the signs symptoms of leptospirosis. And then they might ask you like, which of the following organism is the culprit organism, okay? So this is classically being spread by contact with infected urine, particularly rat urine. Weil's disease should always be considered in high-risk patient with hepatorenal failure. So it causes liver shutdown as well as kidney shutdown. Features are fever, flu-like symptom, renal failure seen among 50% of the patients. There is evidence of jaundice, subconjunctival hemorrhage, headache, and may herald the onset of meningitis. This is a bit rare though, the presentation of meningitis or headache, it's rare. Remember, jaundice, subconjunctival hemorrhage, risk factor, occupational risky job, and hepatorenal failure. In that case, do think of Weil's disease or leptospirosis. Treatment is similar to syphilis, that is high-dose benzyl penicillin or doxycycline. Let's see. So 50-year-old sewage worker presents with 1-week history of fever and feeling generally unwell. Which of the following features would be least consistent with the diagnosis of leptospirosis? Meningism, conjunctival erythema, productive cough, decreased urine output. And let's see, option E is severe myalgia. Which one is the least consistent?
Meningism.
But meningism is actually present though, right? Option E, severe myalgia, but flu-like symptoms will be present. Productive cough. Productive cough is, the respiratory complaints are very, absolutely chances of happening respiratory complaints in leptospirosis is almost 0. So the patient may present with headache, meningism, that's a rare presentation, but compared to the other presentation, the productive cough is the least possible presentation. So that's why if it was not present, if you told me like among the option A, B, D, and E, which one would be least possible, then I would say, okay, maybe meningism. That's one of the possibility. But there is productive cough. So this is something that almost never happens in leptospirosis. So the answer will be productive cough. All right. Treatment of choice, I have already mentioned, benzyl penicillin. Lyme disease, it's a this is a 5-star topic for MRCP part 1, particularly from the infectious disease part, because the skin rash and the tick bite history and the drug treatment, these are all very important. So in early feature, you can see, I would say do not focus on the chronicum word. It's rather commonly known as erythema migrans. So especially they kind of look like the bullseye rash. I'll try to show it here. See? It kind of looks like, have you ever played dartboard? Kind of looks like a dartboard, right? This is known as the bullseye skin rash. So this is known as the erythema migrans skin rash. It's a typical, very typical and characteristic of tick bite, that is Lyme disease. So early feature is the skin rash and the systemic complaints like fever, joint pain, malaise. These are particularly common. And in the late feature, organ involvement will happen. In the heart, it can cause heart block, myocarditis. In the nervous system, it can cause cranial nerve palsy and meningitis. And usually in initial feature, only one large joint is involved. But in the late feature, small joints and more than 2 to 10 joints, they can be involved. So that is polyarthritis. So which one is the following feature not associated with Lyme disease? Can anybody tell? Which one is not seen in Lyme's disease?
Option D.
Option
D, madam.
B, meningitis. It can happen. It can happen in the
D,
feature.
Erythema marginatum.
Sorry?
Erythema marginatum, madam.
Okay.
No,
So
prolonged PR interval.
So erythema marginatum is the correct answer because the rash is erythema migrans, not marginatum, okay? So be very careful. They will play tricks like this. Lyme disease, syphilis, and leptospirosis, all of these are spirochete infection. So in any spirochete infection, after treating with benzyl penicillin and doxycycline, the toxins will be released because of death of the spirochetes. So it will produce triggers in like reactionary changes in the body, like fever, rash, and tachycardia. So this can be seen. This is a common characteristic in all types of spirochete disease. Okay. So investigation is serological test. This is the most important antibodies to the Borrelia burgdorferi. This is Borrelia burgdorferi is a tick-borne disease. So there might be history of mountain climbing or hitchhiking, this type of history. So ELISA test, and among this serological test, the ELISA test, this is the most commonly performed. If the test is positive or equivocal, then immunoblood test for Lyme disease should be done. Management in asymptomatic tick bite, there is no such thing called symptomatic or asymptomatic. All sorts of Lyme disease we have to treat. So tick bites can be relatively common presentation to the GP practice and it can cause significant anxiety. NICE guideline does not recommend routine antibiotic treatment to patients who have suffered a tick bite. In tick bite, you don't have to give the antibiotic. But if tick bite is causing Lyme disease, in that case, whether the patient has any symptom or not, you have to give antibiotic, okay? So management is doxycycline. Here you can see, like in syphilis and in the leptospirosis, the treatment was benzyl penicillin, right? But the first line treatment, it's a bit like reversed for Lyme disease. You can remember it like LD. L is for Lyme disease, D is for doxycycline. So doxycycline if the early disease, amoxicillin is an alternative if doxycycline is contraindicated, for example, in pregnancy. And ceftriaxone if the disease is disseminated, like for example, if the heart block is happening, if the myocarditis is taking place, if the meningitis is taking place, in that case, you can go for the ceftriaxone. As you can see, just like all the spirochete infection, Jarisch-Hersheimer reaction can sometimes be seen after initiating therapy. Let's see, question number 13. So 30-year-old man presents for review 2 weeks after returning from camping holiday in the New Forest. So there is a history of hitchhiking or camping, okay? For the past few days, he has felt generally unwell with lethargy and arthralgia. On examination, he has a rash consistent with erythema chronica migrans, not marginatum. Be mindful. So what's the most appropriate test to perform given the likely diagnosis? Which one is it?
Option A.
A.
Option A, ELISA test, okay? And if the ELISA test is positive or equivocal, in that case, you can go for the immunoblot assay. But ELISA test is the best test to detect Borrelia burgdorferi. Be very, very careful about giving the answer doxycycline, because sometimes what they can do is they can change the entire stem and they can ask you what's the initial antibiotic of choice for treatment of Lyme disease. But if you're not careful enough, then you will miss it and you'll see that the patient was pregnant. And then your answer will be entirely wrong because you cannot prescribe doxycycline in a pregnant patient, okay? Listeria monocytogenes is a gram-positive bacillus, which has the unusual ability to multiply at low temperature. It is typically seen via contaminated food. The key here is the dairy product. Unpasteurized dairy product is the key line from the stem. Infection is particularly dangerous to unborn child, where it can lead to miscarriage. So symptoms for Listeria monocytogenes is it can cause diarrhea, flu-like illness. It can cause atypical pneumonia, meningoencephalitis, ataxia, and seizure. So it can involve the nervous system and the respiratory system and the GIT mainly. Suspected Listeria infection should be investigated by taking the blood culture. CSF may reveal pleocytosis. This is where you put the double mark here, tumbling motility on wet mount. So if you take the CSF fluid and if you examine under microscope, then you will see that the bacillus or the gram-positive bacillus, it moves along the CSF. This is known as the tumbling motility. It's a very highly motile bacillus, okay? So management is Listeria sensitive to amoxicillin or ampicillin. Cephalosporin is usually inadequate. Just remember, like for Listeria, you have to give amoxicillin. It's a gram-positive rod. So most of the gram-positive rod initial treatment will be penicillin group of drugs. Listeria meningitis should be treated with IV amoxicillin or ampicillin and gentamicin. So combination treatment is required for meningitis. In pregnant women, women are immunocompromised, so they are more likely to develop, Listeria monocytogenes. Fetal complications, they can happen. It can pass through transplacental route or even vertical route during childbirth or delivery. Complications are lots of complications. Just give it a read. Diagnosis can be made from the blood culture. Treatment is similar, amoxicillin. So treatment for pregnant and non-pregnant population, this for Listeria monocytogenes is amoxicillin or ampicillin. So which one of the following statement is true regarding Listeria monocytogenes? Anyone?
Option D.
Because ataxia.
Option E. Okay, and
Option B.
option B.
It involves the central
Okay,
nervous
I'm
system.
getting lots of different answers. So first of all, this is a gram-positive bacillus. It multiplies rapidly at low temperature. Okay, it is diagnosed by presence of urinary antigen. This is actually Legionella. Okay, an organism is resistant. It's not resistant. It's actually sensitive to ampicillin, and it may cause ataxia. Actually, I don't know. It should be within D or E, but I think if you compare, then Listeria monocytogenes and Legionella. Why they have put urinary antigen? This is the true answer. So in the future, it can cause ataxia. So option E is actually true. I think option D, option D is false because this is indicative of Legionella. And they're saying that it is diagnosed by the presence of urinary antigen. So that is false. You cannot diagnose Listeria monocytogenes by going for the urinary antigen. Rather, you have to go for either blood culture or CSF study. So the option E, whoever gave the answer, that is the correct answer. So it may cause ataxia. So from gastroenteritis, you have to know about the incubation period, which one has the shortest incubation period, which are the typical organism. So for example, in traveler's diarrhea, most common cause is E. coli or Escherichia coli. Common among the travelers, it causes watery stool and cause abdominal cramps and nausea. So before going through the slide, I'll just randomly pick somebody. Dr. Tan Sing Yang. Dr. Tan, can you hear me?
Yes, ma'am, I'm here.
Okay, so can you tell me which are the organisms that are responsible for bloody diarrhea? Just throw in some common organism that can cause bloody diarrhea.
Salmonella, Shigella,
Yes, okay. And
then E. coli,
the hemorrhagic strain, yes. it can
hemorrhagic
cause-
strain of E. coli, Giardia,
Sorry.
Giardia,
Do you mean Campylobacter jejuni?
Yes.
Okay, and I think you got most of them right. The other one is actually Yersinia pestis, okay? So Salmonella, typical normal enteric fever does not cause bloody diarrhea, but complicated Salmonella or typhoid fever, it can cause intestinal perforation and thereby it can cause bleeding. So bloody diarrhea common causes is actually Shigella, hemorrhagic Escherichia coli, hemorrhagic strain, and then Campylobacter jejuni, Yersinia pestis. These are the common one. And among the entamoeba or the amoeba, Entamoeba histolytica or protozoal infection, it can also cause bloody diarrhea. So if you write it down before going through the chart, then it will be easier for you to pick it up. GRDS is actually, it's one of the causes of chronic diarrhea. It can lead to malabsorption. Cholera, it causes profuse watery diarrhea, lead to dehydration and electrolyte imbalance. That's why management of cholera patient, prompt management, it's very, very important. Otherwise, patient will develop pre-renal acute kidney injury or renal shutdown. Okay. Shigella, it can cause bloody diarrhea, vomiting, abdominal pain. Staphylococcus aureus, it causes severe vomiting and it has a very short incubation period. So most of the food poisoning is caused by Staphylococcus aureus. Campylobacter jejuni, it has a flu-like prodrome, usually caused, it can cause bloody diarrhea, abdominal pain, cramps, and fever. And complications are including Guillain-Barré syndrome. So this is a unique information. So you have to underline this particular information. Bacillus cereus, again, there are two types of illness, vomiting predominant and diarrhea predominant. Vomiting predominant has a short incubation period. It occurs within 1 to 6 hours, and it is stereotypically due to reheated rice or fried rice. And diarrheal illness occurs after the 6 hour. Amoebiasis, it has a subacute onset or gradual onset. It can cause bloody diarrhea and some constitutional features like malaise, fever, abdominal pain, cramps, and tenderness, which can last for several weeks. Amoebiasis, it can also cause another organ involvement. Can anybody tell me? Apart from the intestine?
liver,
Liver, yes, very good. It is also another culprit behind liver abscess, right? There are actually two causes of liver abscess. One is pyogenic liver abscess and the other one is amoebic liver abscess. So here they have provided a classification in involving the incubation period. So the earliest one is within 1 to 6 hours, Staph aureus or the food poisoning culprit. Remember that Staphylococcus aureus itself does not cause food poisoning. Rather, it releases the exotoxin, and the exotoxin is responsible for the food poisoning. Okay, and Bacillus cereus, the vomiting predominant variety, it causes GIT upset. 12 to 48 hours, E. coli and Salmonella or the typhoid fever. 48 to 72 hours, this is Shigella and Campylobacter. And more than 7 days, that is giardiasis and amoebiasis. Okay, so giardiasis and amoebiasis, they are both responsible for chronic diarrhea. Let's see, question number 17. A 23-year-old man develops watery diarrhea 5 days after arriving in Mexico. So which one of the following is the most likely responsible organism? Which one?
Option A.
B. Shigella.
Shigella, but that's watery diarrhea though. So in Shigella, it will not be the answer, right? So you can immediately rule out Shigella, Campylobacter from your options, okay? And there is no
Hence option
history,
E. Bacillus cereus.
Or
but the incubation period is very long. You can see it's 5 days. So which one? Arriving in Mexico, this is traveler's diarrhea. So the culprit organism is Escherichia coli, E. coli. Okay, question number 19. A 24-year-old patient visits to the emergency department with watery diarrhea. He has returned from a holiday in Tanzania yesterday. So which, I think it's a similar one, so I will not go through it. Rather, question 20. A man presents with severe vomiting. He reports not being able to keep fluids down for the past 12 hours. You suspect a diagnosis of gastroenteritis, and on discussing possible causes, he mentions reheating curry with rice the night before. Which one is the causative organism?
Bacillus cereus.
Yes, very good. This answer is Bacillus cereus. Okay, question number 22. A 27-year-old student presents to the GP with 24-hour history of explosive diarrhea and vomiting. On further questioning, he has not noticed any blood in the stool. He has no history of foreign travel. He tells you that he has been eating rice kept warm in a rice cooker for several days. Which one is it?
Bacillus cereus again.
Again, Bacillus cereus. Okay, very good. Let's see. So E. coli, it's a facultative gram-negative rod, and E. coli infection can lead to a variety of disease. Particularly, it can cause traveler's diarrhea or gastroenteritis, urinary tract infection among female, and among very extreme of age, it can also cause meningitis, that is neonatal meningitis. There are certain serotype which is classified according to the antigen present in different parts of the E. coli body. So antigen O is present on the lipopolysaccharide layer, antigen K is present on the capsule, and antigen H is present on the flagellin. And in the capsular antigen K, this is the responsible for neonatal meningitis. E. coli O157H7 strain is particularly, this is the hemorrhagic strain. It can cause severe hemorrhagic watery diarrhea. It has high mortality rate and can be complicated by hemolytic uremic syndrome and can lead to acute kidney injury. It is often spread by contaminated ground beef. So all these three lines are very, very important. So let's see, which one is the following true regarding Escherichia coli infection? You have to find out the true information. So which one is it?
B.
B. E. coli is an important cause of neonatal meningitis. Yes, very good. So cholera, this is caused by Vibrio cholera. It's a gram-negative bacteria. Remember, as a rule of thumb, all the gut or the gastroenteritis culprit organism is gram-negative rod, okay? So features are, it can cause profuse rice water diarrhea, can lead to dehydration and hypoglycemia. Management is ORS or oral rehydration therapy. Among the antibiotic, mainly treatment is by doxycycline. In our country, doxycycline is not well tolerated. So we give the patient ciprofloxacin. However, in the question 26, you can see the answer should be doxycycline. Salmonella, it's an enteric fever causing organism. Typhoid and paratyphoid, there are two types. Variety, Salmonella typhi and the paratyphi. Paratyphi has further three different subtypes, that is A, B, and C. And they are often termed as enteric fever, producing systemic symptoms such as headache, fever, body ache. So I think a lot of us have experienced typhoid by ourselves, right? When we were children, or maybe we ate at a local restaurant or somewhere. And then most of us have experienced enteric fever. So can anybody tell me what are the common features of Salmonella or enteric fever? Without going through this slide, like talk to me about your previous experience, from your own experience. What are the symptoms you have faced?
Fever,
Yes.
abdominal pain.
Usually the enteric fever is high grade, associated with chills and rigor. There might be associated abdominal pain and cough. That is another important symptom. Headache.
Diarrhea.
Diarrhea, yes. Alternating diarrhea, constipation, both of these can occur in case of enteric fever. And in very small percentage of population, some rosy spot, which is that reddish color or pinkish type of skin rash. It can be present in the trunk and more common in paratyphoid rather. So relative bradycardia, that is with 1 degree Fahrenheit temperature change, usually heart rate is increased to 10 beats per minute. But in case of enteric fever, the heart rate is not proportionately increased. This is known as relative bradycardia. So what are the possible complications? Osteomyelitis. Please double put the highlighter on the sickle cell disease. In sickle cell disease patients, Salmonella is the common culprit organism behind osteomyelitis. In normal patients, what is the common culprit behind osteomyelitis? Can anyone tell?
Staph
Staph aureus, yes.
aureus.
In normal individuals, Staphylococcus aureus is the common culprit behind the osteomyelitis. However, in sickle cell disease, Salmonella is. In the intestine, it can cause GI bleeding or perforation. It can cause meningitis, cholecystitis, and it can also lead to chronic carrier in 1% cases, particularly among adult female. So which one of the following is true regarding the Salmonella species?
D.
Option D, very good. So relative bradycardia is often seen in typhoid fever. Shigella, as you have already known, that this causes a bloody diarrhea and abdominal pain, and severity depends on the variants, like which organism or species is causing the shigellosis. So there are different types of Shigella. One is the Shigella sonnei, and it is from the UK. It can be mild, phlegmody or dysentery. These are from abroad. It can cause the severe shigellosis. Treatment is usually with ciprofloxacin. What's the treatment for Salmonella then? Actually, we can take a lot of different antibiotics for Salmonella. Most commonly in our ward, we practice injectable ceftriaxone 2 grams, right? BD. This is done in ward-based management. Cephalosporin group is said to be the most effective one, and azithromycin is as well a good drug for enteric fever. Ciprofloxacin can be used as an alternative. In Shigella, the mainstay treatment is ciprofloxacin. Campylobacter jejuni is.
Excuse me, ma'am.
Yes.
Your voice is coming from very far away.
You guys are having difficulty hearing my voice.
Yeah.
Hmm.
Yeah, madam. It is.
How about now? Do you hear me now?
Better.
Yeah,
Okay.
madam.
I think now it should be okay. Am I clear now?
Yeah, madam. Yeah,
Okay.
yeah.
Yes, ma'am.
So I think it rolled downwards. That's why you guys were having some trouble. All right. So Campylobacter is the commonest bacterial cause of infectious intestinal disease in the UK. So this is not really that common in the tropical areas. Campylobacter is common in the UK region. Majority cases are caused by gram-negative bacillus. Again, like I've said, most of the gut commensal or the gut bacteria or gastroenteritis causing organism will be gram-negative rod. Spread by fecal route, and incubation period is rather long compared to the other organism. This is 1 to 6 days. There is usually a prodrome like headache, malaise, fever. Diarrhea is often bloody, and there is abdominal pain. Management is usually self-limiting. However, if the patient has severe symptom or if the patient is immunocompromised and if the patient is passing lots of loose motion, like more than 8 stools a day, or bloody diarrhea is really bad, in that case, we can give antibiotic, and the first line antibiotic is clarithromycin. So for Salmonella, first line antibiotic is ceftriaxone. For Shigella, the first line antibiotic is ciprofloxacin. For Campylobacter jejuni, the first line antibiotic is clarithromycin. Complications are Guillain-Barré syndrome may follow Campylobacter jejuni infection. Ritter syndrome, this is commonly seen in pediatric population. Okay, Ritter syndrome is rapidly deteriorating SGPT along with splenomegaly and uveitis. This can be present. Another causative risk factor behind Ritter syndrome is among the infectious disease, Campylobacter jejunis. And septicemia, endocarditis, arthritis, these are some other complications. But the most important one is among adult population, Guillain-Barré, and among the pediatric population, Ritter syndrome.
And in
So-
the Guillain-Barré, the neuropathy will be ascending or descending.
Sorry, the Guillain-Barré.
Yeah.
Okay,
The
Guillain-Barré,
neuropathy will be
yes, Guillain-Barré syndrome is
will
actually lower motor neuron type of variety, and it causes ascending type of paralysis, okay? So it starts usually from the lower legs and then gradually causes ascending variety. And there is another descending variety. So it particularly involves the bulbar muscle, respiratory muscle, and the face and the truncal muscle initially. This is a subvariant of the Guillain-Barré syndrome known as the Miller-Fisher, okay? So Miller-Fisher is a triad of ataxia, reflexia, and ophthalmoplegia. In the Miller-Fisher variant, there is descending variety. And typically GBS is an ascending variety. So the legs are involved more. If a Guillain-Barré syndrome patient presents with a
Okay.
descending variety, in that case, this is usually indicative of poor prognosis. Okay. So let's go for amoebiasis. So amoebiasis is caused by entamoeba histolytica. This is actually a protozoal infection spread by fecal-oral route. 10% of the world's population is already chronically infected with the amoebiasis. Infection can be asymptomatic, can cause mild diarrhea or severe amoebic dysentery or bloody diarrhea. Amoebiasis can also cause liver and colonic abscess. So amoebic dysentery usually causes profuse bloody diarrhea. Stool microscopy shows motile trophozoite, and treatment is with metronidazole. So it's a protozoal infection, of course. With the protozoal infection and for anaerobic infection, we usually give metronidazole. Amoebic liver abscess, mainly it causes single mass in the right lobe, can be multiple sometimes, but commonly single mass. And features are fever and right hypochondric tenderness and pain. Serology is positive in more than 90% of the patient. So tetanus is caused by tetanospasmin exotoxin, which is, it's a toxin-mediated manifestation, tetanus. This is not directly caused by the Clostridium tetani, rather it's an exotoxin-mediated manifestation. Tetanospasmin, there are actually different types of exotoxin, tetanospasmin, tetanolysin. So among this exotoxin, tetanospasmin is the culprit exotoxin that is released from the Clostridium tetani. Tetanus spores are predominantly seen in the soil, and they can be introduced into the body from a wound, which is often unnoticed. So if you're walking barefoot and if you have a cut injury, you have a very high risk of contracting tetanus, okay? Which is why tetanus TT vaccine is given in almost all injury, cut injury or wounds. So features are prodromal fever, lethargy, headache, trismus, which is painful lockjaw. So the temporomandibular joint becomes fixed and tender, which is why patient is not able to move the jaw. So Rhizus sardonicus, it's actually, this is a Latin for Satan-like smile. So because of the painful muscle contraction around the mouth, patient usually has some painful grimace. It mimics the Satan smile. This is known as the Rhizus sardonicus. Opisthotonus, this is actually a position. So the back muscle is very much spasm. So that's why patient is actually arched back and neck is hyperextended. And painful spasms are also seen in internal muscles as well for muscles of deglutition, leading to painful dysphagia. So management is basically supportive treatment. You have to give ventilatory support and muscle relaxant to the patient. Intramuscular human tetanus is so once the patient has contracted tetanus, you have to give the patient both active passive immunization. Intramuscular human tetanus immunoglobulin for high risk wound. This is actually the patient hasn't already developed tetanus, but the patient might be contracting it. In that case, in order to prevent it from happening, you can give the immunoglobulin. Sorry. Okay. So who are the high risk group? In compound fracture, delayed surgical intervention. For example, a patient has a degloving injury from the road traffic accident, and the patient has been referred from one hospital to another, and the surgical intervention has been delayed. So that's a high risk group. And significant degree of devitalized tissue. That is particularly also true for degloving injury. So in those patients, you have to give the IVIG, okay? And metronidazole is now preferred to benzyl penicillin as the antibiotic of choice. So basically, you have to give the patient, you have to take the patient to a well-ventilated room. It should be dark and calm and quiet, and there should be muscle relaxant available. You should give the patient metronidazole, and active passive immunization if the patient has already contracted the tetanus. But if the patient has not contracted tetanus, but is a high risk group, in that case, you have to give the passive immunization. But if the active immunization history, like tetanus vaccine history, is not found, in that case, you have to go for the active passive immunization both. So in tetanus vaccine, normal tetanus vaccine regime is once a baby is born, the first 3 doses are given at 2 months, 3 months, and 4 months. The 4th dose is given within 3 to 5 years, and the final dose is given within 13 to 18 years. In our country, it is given within 15 to 18 years. So 5 doses of tetanus containing vaccine is given, and this is said to be, quite adequate or long-term protection against tetanus. Intramuscular human tetanus immunoglobulin, again, given to the high-risk group. If the vaccination history is incomplete or unknown, then a dose of tetanus vaccine should be given in combination with the passive immunization. So which I've already mentioned, like if a high-risk group, like for example, degloving injury, a significant amount of devitalized tissue, patient surgical intervention has been delayed for some reason. In that case, you have to go, and the patient is not able to remember whether he was given TT vaccine before or not. In that case, you cannot take any chance. You have to give both active and passive immunization. So question number 34, a 19-year-old man presents with compound fracture in his leg following a fall from scaffolding. Examination reveals soiling of the wound with mud. He is sure that he has had 5 previous tetanus vaccination. He's sure that he completed his tetanus vaccine, but this is a high-risk group. Okay, so now what's the most appropriate course of action to prevent the development of tetanus?
C.
Okay.
No, answer B. Clean wound plus tetanus vaccine.
So answer is okay, A.
A.
Because A. He has already have 5 previous tetanus vaccines, so there is no need to give the tetanus vaccine again. And the patient is a high risk group, so you have to give the IVIG or the immunoglobulin. No need to go for the active passive immunization because patient has, maybe the patient already showed that the TT vaccine is given, completed, the card is showing, okay? So in that case, then you don't have to go for the active passive. You have to go for active passive immunization only when the dosing is incomplete or the history is not properly evaluated. In that case, you can go for active passive immunization. Okay. Botulism, this is caused by Clostridium botulinum. It's a gram-positive anaerobic bacillus. There are 7 serotypes from A to G. It produces botulinum toxin, a neurotoxin, which irreversibly blocks the release of acetylcholine. So it kind of mimics the effects of myasthenia gravis. I don't want to overcomplicate it. In myasthenia gravis, what happens is circulating autoantibodies are formed against the acetylcholine receptor at the neuromuscular junction. So it blocks the release of the acetylcholine, so it causes inappropriate or improper muscle contraction. Botulism kind of works in a very similar way. The toxin irreversibly blocks the release of acetylcholine, basically, and it may result from eating contaminated food, like particularly tinned or canned food. The neurotoxin often affects the bulbar muscle and the autonomic nervous system. So botulism causes actually descending type of paralysis. GBS causes ascending type of paralysis. Miller-Fisher, a rare variant of GBS causes similar to the botulism, descending paralysis. Is that clear? So neurotoxin often affects the bulbar muscle and autonomic nervous system. Features are patient usually fully conscious. There is no sensory impairment. Patient has flaccid paralysis or paraplegia. Patient might be having diplopia, so might be having ataxia as well or bulbar palsy. So bulbar palsy can lead to dysphagia and dysarthria. Sometimes respiratory muscle weakness can also develop from botulism. Treatment with antitoxin is only effective if given early, but once the toxin is bound to the receptor, the action cannot be reversed because it causes irreversible blockage to the acetylcholine. Therapeutic, but however, we use botulinum toxin in so many aspects in our clinical life. Especially, it's a very important toxin that is used in dermatology or aesthetic medicine, right? So it can be helpful in strabismus, dystonia, that is torticollis and blepharospasm. Torticollis is basically painful neck contraction, and blepharospasm is abnormal, irregular movement of the eyelid. hyperhidrosis in patients who are refractory to the pharmacological management of hyperhidrosis, and you have evaluated all the causes. There is no underlying cause behind excessive sweating. In that case, botulinum toxin can be given. For cosmetic purpose, Botox is given. Serotype A of botulinum toxin is used. This is commonly used among the celebrities, particularly to get rid of the crow's feet around the eye here, and to get rid of the frontal wrinkling. Okay. So muscle is abnormally contracted here, which is why you don't see any contraction or whenever we show any facial expression, there is some wrinkling happening, right? Around our mouth, around the eyebrows, along the lateral surface or corner of our eye. But after giving the botulinum toxin, so it prevents the release of the acetylcholine. Okay, so there is no muscle contraction in there, which is why it will be completely smooth. There will be no wrinkling at all. So 42-year-old female presents to the emergency department. She is known to be having intravenous drug user and sometimes practices skin popping. She has multiple sores and wounds. She is complaining of double vision, difficulty in swallowing, slurred speech, and weakness of the arm muscle. Her arms are weak and floppy. You suspect that a bacterial toxin is causing her symptom. So what is the mechanism of action of the most likely toxin? Which one is the answer? Option B. Very good. Clostridium difficile, again, this is a 5-star important topic. So it's a gram-positive rod, often encountered in hospital practice, right? Have you ever encountered any Clostridium C. diff infection in the hospital setting? Anyone?
Yes.
You have? So which antibiotic was the culprit antibiotic for your patient? Doctor? So there are several broad spectrum antibiotic. Okay, after giving that, what happens is in the normal, in our gut, there is a normal gut commensal or gut microbiota, right? So if you give broad spectrum IV antibiotic, it causes some shifting in the dynamic of the gut commensal. So the upper hand is actually given to some opportunistic infection like Clostridium difficile, which is why it causes pseudomembranous colitis and thereby causing profuse watery to sometimes it can also cause bloody diarrhea as well, the C. diff infection. So particularly seen among the immunocompromised patients, it develops when the normal gut flora are suppressed by the broad spectrum antibiotic, clindamycin, which was previously used. This is one of the culprit antibiotic. However, second and third generation cephalosporin, even clarithromycin can cause Clostridium difficile infection. Features are after starting the antibiotic treatment, within 2 to 3 days, patient will complain of diarrhea, abdominal pain, but the raised WBC count is actually characteristic in the complete blood count. And if it is not treated properly, then it will lead to severe toxic megacolon. Diagnosis is made by CDT in the stool, which is known as the detection of Clostridium difficile toxin, CDT in the stool. Management is first line is oral metronidazole for 2 weeks. If severe or not responding to metronidazole, then oral vancomycin can be given. In life-threatening infection, a combination of oral vancomycin and IV metronidazole can be used. So treatment is either vanco or metro. So what are the risk factors? The risk factors are broad spectrum antibiotics. We have already gone through that. Among these antibiotics, clindamycin, second and third generation cephalosporin, plus minus clarithromycin. These are the most common culprit antibiotic. Use of proton pump inhibitor and H2 receptor blocker, it can also show some significant impact. And if a patient, for example, if a patient who's receiving antibiotic for pneumonia and the patient is placed right next to a patient who has just suffering from C. diff infection. So with the contaminated bedsheet, there is also a chance of contracting this infection. So contacted with person infected with C. diff. It's another way for possible transmission.
Madam, excuse me. Why it is proton pump inhibitors and H2 block receptor antagonist?
Actually, there are no like significant studies saying that these are the culprit medication. However, sometimes with the proton pump inhibitor, high dose and the H2 receptor antagonist, it disrupts the acidic environment in the stomach. So in the stomach, you do need the acidic environment, okay, it causes some bactericidal effect. So if you go for high dose proton pump inhibitor and the H2 receptor antagonist, what it does is it can lead to hypochlorhydria or achlorhydria, okay? That is suppression or complete cessation of hydrochloric acid formation. So in that case, these are favorable, outcome for bacterial colonization. So this is one of the hypotheses that is thought to be responsible for C. diff infection. But most importantly, broad spectrum antibiotic, these have been proven that they are the main culprit for C. diff infection. Okay?
Thank
you. You're welcome. So question number 37, 93-year-old woman is seen on acute ward round with refractory C. diff infection. She has already received 2 weeks of oral metronidazole, oral vancomycin, and IV metronidazole. So which one is the following may be implemented as the next line of management? So the patient is actually receiving lots of medication, the oral metro, oral vanco, and IV metro. I haven't gone through this, but let's see if you actually have dealt with the C. diff infection, then you might know the answer. So which one is actually the answer is there? Can anybody tell me? Take a wild guess.
Vancomycin.
I think patient is already receiving vanco, metro, and IV metro.
Option C.
C, fidaxomicin. Yes, this is actually given in patients who are refractory C. diff infection, refractory to oral and IV metro and vanco combination. In that case, you can go for the fidaxomicin. And I'm pretty sure that this will not come in your exam, just for general discussion, as I had a very small assignment, which was I had to write a biological essay on the Clostridium difficile infection during my master's course. So we had a flow chart, okay? So the flow chart was, first is oral metro. If not working, go for oral vanco. If not working, go for oral vanco plus IV metro. If not working, go for oral fidaxomicin. If not working, then gut microbiome implantation. Can anybody tell me what is gut microbiome implantation? It's actually a rather very weird and bizarre practice, but it shows a lot of significant improvement. This is not done in our country.
It's taking the stools from a normal healthy one, and they will be inserted to the C. diff infected patient in order to enhance the growth of microbiome in those patients.
Excellent, very good. So they do a colonoscopy, okay? So they take the stool sample from a healthy individual and put that stool, like a very small amount, through colonoscopic procedure and put it in the diseased gut. And within just a couple of days, the patient usually shows significant improvement. This is not routinely done in our country. Excellent. Who has said that?
Kamlat, madam.
Doctor?
Kamlat, madam.
Okay, very good. Do you work in India?
No, madam, Sri Lanka.
Sri Lanka, okay, excellent. All right, next up is, I think you'll able to get that. So which one of the following antibiotic is most likely to cause pseudomembranous colitis? It's a little bit confusing, isn't it?
Cefuroxime.
Cefuroxime. And any other guesses?
Cephaloxime also, madam. Third generation cephalosporins.
So you're confused between A and B, right? Actually, cephaloxime is not a second generation. Cephaloxime is actually, as far as I can remember, this is a first generation cephalosporin. So second and third generation cephalosporin will be given top priority. Okay. So the answer is cefuroxime. Okay. Next up, question number 44. 78-year-old man is being treated on the medical ward with coamoxiclav for a lower respiratory tract infection. After 3 days, starts to experience loose stool, passing 2 to 3 offensive stools per day, but systematically well. First line choice of therapy. What is the answer?
Metronidazole.
Metronidazole. Yes, very good. Cat scratch disease, sometimes they can give you like which one is the a 9-year-old boy comes to the emergency department with a high-grade fever, and on examination you found there is a tender axillary lymph node. And on a query, the patient gave history of cat scratch a few days back. So which, and you take the swab or maybe some tissue sample from the enlarged lymph node. And if you go for the microscopy, you show that there is a evidence of gram-positive rot. So which of the following is the causative organism behind this disease? So Bartonella hanseli is the answer. Features are fever, history of a cat scratch, regional tender lymphadenopathy, headache and malaise. These are usually the symptoms. So the organism name is actually important for cat scratch disease. Next topic is sexually transmitted infection or the ulcers. Now let's talk about it. Tell me some important causes of genital ulcer. Don't mind about the painful or the painless. Just mention the names. What are the causes of genital ulcer?
Herpes simplex virus.
Herpes simplex, very good. And?
Tribonoma bellidum.
Sorry?
Tribonoma bellidum.
Yes, very good.
Syphilis.
And? Syphilis, yes, good. So herpes
Chancre.
simplex, syphilis. Chancre is actually caused by syphilis. And? Anyone else? Would you like to?
I don't remember, but there is something called as Ducry and lymphogranuloma venereum. I don't know whether they are
Okay,
STIs
yes.
or.
Okay, yes, very good. I'm happy that you guys are able to remember 1 or 2 names from back our MBBS or the undergrad level, right? We used to go through this a lot, this information. So this is just a recapitulation. Genital herpes is the most common one, caused by herpes simplex type 2. Cold sore are usually caused by type 1, okay? So don't mix these two up. I think in our, like I have seen in our clinical setting that a lot of patients, because of immunocompromised state, they suffer from herpes labialis, okay? And they face so much backlashes because most of the people think that herpes labialis is also contracted from sexual or promiscuity, but this is not really that case. Cold sore can happen to anybody. This is not a sign of promiscuity or anything. Genital herpes, on the other hand, this is usually seen among people who are more exposed or to, sexual contacts more, they have lots of partners or something. But herpes labialis or the cold sore, this is never ever a sign of promiscuity or anything. So never judge a patient just because he has herpes labialis or, oral ulcer because of herpes. Primary attacks are often severe and associated with fever, while subsequent attacks are generally less severe. Genital herpes related ulcer is very much painful, okay? Remember that. Syphilis, it causes painless ulcer, which is known as chancre, and it can also cause non-tender lymphadenopathy. I have already gone through the syphilis information. Chancroid, this is a tropical disease caused by Haemophilus ducreyi. It causes painful genital ulcer and painful lymphadenopathy. Lymphogranuloma venereum, this is caused by Chlamydia trachomatis. Typically, infection comprises of 3 stages. So you don't have to remember all these 3 stages. Just remember in the stage 1, the ulcer is formed. In stage 2, there is painful lymphadenopathy. And in stage 3, there sometimes even rectum can be involved, leading to proctocolitis. Here, unlike these, I have already mentioned, like herpes causes painful ulcer, and syphilis causes painless ulcer and painless lymphadenopathy. Chancroid causes both painful ulcer and painful lymphadenopathy. LGV is a bit different because the ulcer is painless, but the lymphadenopathy is painful. So LGV is treated using doxycycline. Other causes of genital ulcer, Behçet's disease. This is actually an immune-related disease where there is recurrent oral genital ulcer. This is the clue. And along with that, patient usually has small vessel vasculitis. So patient might be having skin rash, joint pain, and They might be having these. This is also a prothrombotic condition. So they have more chances of developing clot formation like stroke, myocardial ischemia, pulmonary embolism. These kind of complications are common in Behçet's disease. This will be covered actually in the new rheumatology class, so don't worry. Carcinoma or malignancy, of course, you have to rule out for any genital ulcer. Granuloma inguinale, it's actually a rather uncommon infection. This is caused by Klebsiella granulomatous, previously known as, you don't have to remember that, just remember granuloma inguinale. Okay, a 28-year-old man who has recently immigrated from Nigeria presents with a penile ulcer. It initially started as a papule, which later progressed to become a painful ulcer with an undermined ragged edge. Examination of the testes were unremarkable, but tender inguinal lymphadenopathy was noted. So which one is the most likely diagnosis? So Nigeria, remember, that's a tropical country. So what's the diagnosis? But the ulcer and the lymphadenopathy is painful. So the answer is?
Herpes.
Herpes. Okay, we'll go through these information again. So chancroid, it's a tropical disease caused by Haemophilus ducrei. It causes painful genital ulcer associated with painful lymphadenopathy. Now here, the answer is chancroid, right? Because Nigeria, that's a tropical country. Penile ulcer, which started as a papule, later progressed to become a painful ulcer, and there is painful or tender lymphadenopathy. So very much suggestive of chancroid. A 20-year-old student presents complaining of multiple painful ulcer on the shaft of his penis. So this is painful ulcer, okay? And he tells you that he has had a new sexual partner recently, but she has not reported any symptom. He feels generally unwell and has tender enlarged inguinal lymph nodes bilaterally. So this is a bilateral tender lymphadenopathy. He denies urethral discharge or dysuria. So what's the most likely diagnosis? This is a common presentation in the clinical setting, actually. Compared to chancroid, this is very common.
Is it D? Is it D, lymphogranuloma venereum, chlamydial problems?
No. Actually, LGV, it causes painless ulcer. But here there is mention of painful ulcer. Painful ulcer and bilateral tender lymphadenopathy.
Herpes.
So herpes.
Yes, herpes,
Second
yes.
option would be herpes.
Yes, option B is the correct answer, okay? Herpes simplex. This is the last question from the genital ulcer section. So 35-year-old homosexual man is referred to the local GUM or the genitourinary clinic following the development of solitary painless penile ulcer associated with, that is painless, okay? Associated with painful inguinal lymphadenopathy. I think you guys have been giving me this answer ever since I started questioning, right? So the answer is very obvious, LGV, right? Okay. So I think all of you have got like which is the correct answer from the genital ulcer section, right? So remember that both painful ulcer, bilateral tender lymphadenopathy, suggestive of herpes simplex. Painful ulcer and unilateral painful tender lymphadenopathy, suggestive of chancroid. Painless ulcer, painless lymphadenopathy, chancre or syphilis. Painless ulcer, painful lymphadenopathy, LGV. Now let's discuss about, where is it? Chlamydia. This is actually very, very common. In all the sexually transmitted infection, herpes is very common. Chlamydia is very common. Gonorrhea is common. Rather, syphilis, LGV, granuloma inguinale, Haemophilus ducrei, these type of infections are rather rare. But herpes is common, chlamydia is common, and gonorrhea. These are common sexually transmitted infections.
Ma'am, I do have question.
Yes?
Is herpes simplex virus have a bilateral painful lymphadenopathy?
Sorry, I didn't get your question. Can you ask me again?
Okay. Is a herpes simplex virus have a bilateral painful lymphadenopathy?
Yes, herpes simplex can cause no lymphadenopathy, or when it does, it usually involves both side tender lymphadenopathy. Okay.
Okay, thank you.
There might be just simple one single painful ulcer, multiple painful ulcer with or without bilateral tender lymphadenopathy. Unilateral tender lymphadenopathy is characteristic for Haemophilus ducrei. However, look for clues like if there is any mention of tropical country. If there is no mention of tropical country, the answer is still going to be herpes simplex, because herpes simplex is more common than chancroid. So chlamydia is the most prevalent sexually transmitted infection in the UK caused by Chlamydia trachomatis. It's an obligate intracellular pathogen. Approximately 1 in 10 young women in UK have chlamydia. The incubation period is around, so you can see this is very common. 1 in 10 young women, this is very, very common and very alarming actually. The incubation period is around 7 to 21 days, although it should be remembered a large percentage of cases are mainly females. Females are usually asymptomatic. Male, they usually have some symptoms like dysuria and some discharge, but women tend to be asymptomatic more. So potential complications are, in male, it can cause epididymitis. In female, it can cause pelvic inflammatory disease or PID and endometritis, increased incidence of ectopic pregnancy, infertility, reactive arthritis. So when you go in the rheumatology section, I will discuss about the seronegative arthropathies. And among the seronegative arthropathy, reactive arthritis is one of the common examples of seronegative arthritis. And usually there is a preceding gastrointestinal infection or some genitourinary infection. And among the genitourinary infection, chlamydia is one of the culprit causes of reactive arthritis. You don't have to bother about this, just know about the complication right now. Perihepatitis, also known as Fitzhugh-Curtis syndrome, this can also be seen in the chlamydia infection. Investigation is, as this is an intracellular obligate organism, that's why traditional cell culture or media will not be optimal for its growth, which is why you have to go for some other type of testing. So one of the important tests is nucleic acid amplification test or NAT test. And urine sample or the vulvovaginal swab or cervical swab can be taken as a sample to go for the NAT test. In case of male, the first void urine sample. In case of female, the vulvovaginal or the high cervical swab is usually taken. In England, as this is a very prevalent condition, which is why they have started the National Chlamydia Screening Program. It's open to all women and men of reproductive age group, particularly among the young group. And they have suggested that all sexually patients aged 50 to 24 should undergo this screening procedure. And treatment is, when a patient is down with chlamydia, what do we give? We give 7-day course of doxycycline. However, doxycycline can cause some side effects like esophagitis, okay, and it's considered teratogenic. So that's why, and it requires 7-day course. So instead of going for a 7-day course, it can lead to non-compliance, which is why they have come up with single dose 500 milligram azithromycin, because it's easier to give. It just requires only 1 dose. You give the patient azithromycin, patient is symptom-free. So if pregnant, then consider erythromycin or amoxicillin. Azithromycin is plus minus in the pregnancy category. Patient diagnosed with chlamydia should be offered a choice of provider. Like for example, if a girl is down with chlamydia, then of course partner notification should be done. Especially a recent sexual partner should be notified so that he can be given a single dose of azithromycin. For men with symptomatic infection, all partners for 4 weeks prior to the onset of the symptoms should be contacted. Women and asymptomatic men, all partners from last 6 months or the most recent sexual partner should be contracted. This is just for, nice to know information. Contacts of the confirmed chlamydia case should be offered treatment prior to the results. So this is so prevalent that they're not even bothered of testing it. So one person is down with chlamydia. He says that, okay, I have a girlfriend. No need to check the girlfriend, whether the girlfriend is having chlamydia or not. Just give the girlfriend azithromycin. That is their protocol. So let's see, question number 52. A 19-year-old man presents with dysuria associated with watery discharge from his urethral meatus. A urethral swab shows non-specific urethritis and the urine is sent for chlamydia or the gonococcus. What is the most appropriate antibiotic to use at this stage? Sorry?
Metronidazole.
Metro. But they're suspecting it a case of chlamydia or the gonococcus. Yes, azithromycin.
Azithromycin.
Azithromycin or doxycycline, that is the answer. But doxycycline is usually 7-day course. So we prefer the azithromycin. And besides, doxycycline is not even in the option. So 27-year-old pregnant woman is found to have chlamydia, and she reports to being allergic to penicillin. Now tell me, what's the most appropriate treatment? You cannot give doxycycline to a pregnant woman. Very good.
Erythromycin.
Erythromycin. Okay. Let's see. Gonorrhea, this is a gram-negative diplococcus, Neisseria gonorrhea. Acute infection can occur in the mucous membrane surface, typically genitourinary, but it can also involve the rectum and the pharynx. It mainly depends on the way of sexual exposure is taking place. Among the homosexual men, the rectal gonorrhea and the pharyngeal gonorrhea, this is more common. The incubation period for gonorrhea is 2 to 5 days. So it's a very short incubation period. The symptoms are typically present within a very short duration of time. In chlamydia, the incubation period was 7 to 21 days. That is 1 to 3 weeks. It takes a longer time. In case of male, there is evidence of urethral discharge and dysuria. Females have cervicitis leading to vaginal discharge, and rectal pharyngeal infection is usually asymptomatic. Local complications may develop include urethral stricture. So repeated infection can cause stricture formation, and it can lead to epididymitis, salpingitis in case of female, and lead to infertility. So now, can anybody tell me whether why males suffer from infertility, but female will be having subfertility with long-standing gonorrheal infection? Why is the reason? Anyone? Okay, this is actually a GK thing, okay? Not that critical, actually. So I'll try to show it. Yes, go on. So male, remember, in case of male, for the sperm to be ejaculated, the only pathway is through the urethra. So with recurrent infection, there is chances of urethral stricture formation. So of course, only one thing is there, and that is also blocked. So it will lead to infertility. But in female, there are 2 fallopian tube, right? So even if one fallopian tube is blocked, there is another fallopian tube that is ready for ovum production and for subsequent gestational changes. So in that case, usually in gonorrhea, female, they suffer from subfertility instead of infertility.
Madam, excuse me. Is it reason for dysmotility, cilia?
Sorry?
Like in the dysmotility of cilia, it can be in fallopian tubes or somewhere.
I'm sorry, I didn't get your question. Can you
Cilia,
repeat it?
I mean, dysmotility of cilia, like Cartagena syndrome. Because of
No. Cartagena is completely different. Cartagena is the ciliary immotile or dysmotility syndrome. That's congenital abnormality. But the stricture is happening because, okay. So in case of gonorrhea, there is recurrent infection. Recurrent infection can cause recurrent inflammation. And with recurrent inflammation, there is blockage of the urethra. Okay. So that's why the stricture develops in long-standing cases. And in case of female, there are 2 fallopian tubes. So even with consequent or subsequent changes happening in one fallopian tube, the other fallopian tube is fine. So the female patients usually suffer from subfertility. I think the one you are talking about, you have messed it up with cystic fibrosis patient. In cystic fibrosis patient, males tend to have infertility and females tend to have subfertility, not because it is not related to infection or inflammation or anything, because in cystic fibrosis, what happens is the luminal secretion becomes thick and viscid. So it becomes blocked, right? In cystic fibrosis, the sodium and the chloride concentration becomes very much thick and viscid in the secretion, which causes blockage in the luminal structures, which is why in the seminal vesicle or the seminiferous tubule or the vas deferens, these are blocked because of the thick viscid mucus, and that can lead to infertility in male. But in case of female, this same type of thick viscid secretion usually causes unilateral blockage, but the other side is usually not, or maybe not symmetrically involved. So subfertility is seen in cystic fibrosis as well. These are two different mechanisms. One is infection-related gonorrhea, and the one you're mentioning, that is completely different. That is cystic fibrosis, okay? It's a genetic condition, autosomal recessive. All right. So in gonorrhea, treatment is mainly ceftriaxone. Ceftriaxone is used for the gonorrhea treatment. So most of the time, this sexually transmitted infection, there is co-infection of gonorrhea and chlamydia, which is why IV ceftriaxone and tablet azithromycin is given. Okay, disseminated gonococcal infection. This is an important topic, and gonococcal arthritis. These are complications of gonococcal infection. One of the common causes of septic arthritis in young adults is gonococcal arthritis, actually. Pathophysiology of disseminated gonococcal infection is not fully understood, but this is thought to be due to hematogenous spread. Asymptomatic, no, you don't have to go through that. In case of the DGI, the usual characteristics of the triad of symptoms are tenosynovitis. So it can lead to heel pain, shin pain, something like that. And migratory polyarthritis, joint pain, and dermatitis. Lesions may be maculopapular or vesicular. So joint pain, skin rash, and heel pain. These are characteristic of disseminated gonococcal infection. So 19-year-old woman reviewed at the genitourinary medicine clinic. She presents with vaginal discharge and dysuria. Okay, vaginal discharge and dysuria. Microscopy of an endocervical swab shows gram-negative coccus that was later identified as Neisseria gonorrhoeae. This is her third episode of gonorrhea in the past 2 years. So this is the third time episode of gonococcal infection in a case of female. What is the most likely complication from repeated infection? Is it Fitzhugh-Curtis, cervical cancer, arthropathy, infertility, uterine abscess? Which one? Fitzhugh. Okay, is it common though?
Infertility.
It is subfertility with female.
Uterine abscess.
Arthropathy. Common complication, 3 episodes of gonorrhea. Infertility is the answer. You have to remember the local complications first. Then you think about the other complication, like the other organ involvement or distant complications or remote complications. Most common cause of the reason why I mentioned like why females suffer from subfertility and why males suffer from infertility, it was just a general knowledge thing. But more or less, everybody suffers from subfertility issues because of the repeated gonococcal infection. So if this is a case of third episode of gonorrhea, then of course you have to think about whether the person will subsequently develop fertility issues in the future term. They're not asking you whether the patient will have subfertility or infertility, right? So among all these options, infertility is the correct answer. Okay, question number 58, please, Dr. Neha. Dr. Neha, can you unmute yourself and read it out?
Yes, ma'am. Infertility secondary to pelvic inflammatory disease is the most common complication of the gonorrhea. It is the second most common disease cause of PID after chlamydia. Fitzhugh-Curtis syndrome, a complication of PID,
No.
arthropathy may
Okay, Dr. Neha, you're reading the explanation. Question number 58.
Oh, I'm so sorry.
No problem.
I'm so sorry. Yes, ma'am. A 23-year-old male present with a purulent urethral discharge. A sample of the discharge is shown to be gram-positive
Gram-negative
Diplococcus.
Diplococcus.
Gram-negative Diplococcus.
Yes.
What is the most appropriate antimicrobial therapy? Option A is oral ciprofloxacin for 7 days. Option B, oral penicillin B for 5 days. Option C, oral doxycycline for 7 days. And option D, oral azithromycin stat dose, and option E is intramuscular ceftriaxone stat dose plus oral azithromycin stat dose.
So which one is the answer?
Could it be E, intramuscular ceftriaxone stat dose with oral azithromycin stat dose? Because
Yes.
purulent
Yes,
urethral
ma'am.
discharge could be because of gonorrhea, and if it is gonorrhea, it could be, concomitant with chlamydia as well.
Chlamydia,
So
yes, very
option
good. Very good. And also be mindful that the patient sample is showing gram-negative. So the gram staining is showing gram-negative Diplococcus. And as the chlamydia is an atypical infection, so it will not show up in the gram stain or the culture. So you have to be on the safe side and think of the co-infection and treat it anyway, okay? So the answer is IM ceftriaxone stat dose along with oral azithromycin. Very good. Okay, what time is it? So I will actually be back after taking a 5-minute break because I have to pray. So drink water, have some coffee, and I'll be back within 10 minutes. Thank you. কোথায় গেল আরেকটা? না একটু পরে। So welcome to the second phase of today's discussion. We will start with pelvic inflammatory disease, one of the consequences of sexually transmitted infection. It's a term used to describe infection and inflammation of the female pelvic organ, particularly the uterus, fallopian tube, and the ovaries surrounding peritoneum, resulting this is a consequence of the ascending infection from the endocervicitis. Causative organism, most common causes are chlamydia trachomatis, Neisseria gonorrhoeae, mycoplasma, hominis, and genitalium. So you can remember it by CNM. Features are lower abdominal pain, fever, dyspareunia. Sometimes back pain can be associated, and some discharge or urethral or vaginal discharge may be present. Investigation is screening for chlamydia and gonorrhea because these are the most common culprits. So you have to screen this both. You can take the swab, high vaginal or the vulvovaginal or the high cervical swab, and send it for the culture sensitivity and the gram stain. And for the chlamydia, you can do the NAAT amplification test or PCR. Management is due to difficulty in making an accurate diagnosis. Potential complication of untreated PID is, that's why they have lower threshold for guidelines. So if you're suspecting it a case of PID, even without going for the high vaginal swab and the endocervical swab, you can start with the empirical antibiotic treatment because the complication of PID is more than if you are not treating the PID patient. So normally oral ofloxacin, which is a fluoroquinolone drug, and oral metronidazole in order to cover the anaerobes and the protozoal infection. This is given, or intramuscular ceftriaxone plus oral doxycycline plus oral metronidazole. This is another regimen. Sometimes intramuscular ceftriaxone plus oral azithromycin plus oral metronidazole, that can also be given, okay? So remember, oral intramuscular ceftriaxone is for gonorrhea. Doxycycline is for chlamydia. Metronidazole is for protozoal infection and anaerobes. Complication or infertility, risk may be as high as you don't need that. Just remember complication, chronic pelvic pain, and it can lead to ectopic pregnancy. Let's go for this question number 60. So doctor, you read about the question 60.
And dyspareunia and some postpartum bleeding. Large European finger in suprapelvic area and vaginal junction with the cervical expanded shrine. The cervical slots of management.
Very good. Oral ofloxacin and metronidazole. This is the good combination. Or you could go for IM ceftriaxone plus oral doxycycline plus oral metronidazole. All right. Epididymoarthritis, these are consequences of chlamydia and gonorrhea infection. I'm not going to secondly repeat it. Just go through it, give it a read just once. It's maybe a one-star topic. Vaginal discharge, this is again, it's a rather important topic. This is at least 3-star important topic. Vaginal discharge, there are 3 different organisms, okay? One is trichomoniasis and the other one is candida and the other one is bacterial vaginosis. So what are the 3, so in these 3 categories, what are the common clinical features? You have to know about that. Apart from the infectious cause, there is some common causes like physiological cause. So for example, if a person or if a female person who is not keeping normal hygiene or maintaining normal hygiene, if junk food, lack of hygiene, using nylon or synthetic undergarments, they can all cause vaginal discharge or irritation, okay? So there are some less common causes. One of those are like chlamydia and gonorrhea. They can cause vaginal discharge. However, this is a rarely presenting symptom. In male, it can cause urethral discharge more commonly, but in female, chlamydia and gonorrhea, they can cause vaginal discharge or cervical discharge, but mostly asymptomatic. And if the discharge is happening, it usually is in the form of cervical discharge rather than vaginal discharge. And other less common causes would be ectropion, which is basically changing of the lining of the cervical lining, foreign body, and cervical cancer. This is a very rare cause of vaginal discharge. It particularly takes place in older people. There is actually a bimodal presentation, as far as I can remember, for cervical cancer. One can take place in the mid-30s and the other one takes place in around the mid-60s to 70s. And cervical cancer, there is some risk factor, and of course there is postcoital bleeding and some constitutional symptom like weight loss, anorexia, loss of appetite, such things like that. So what are the key features? This is very, very important. Just give it like a couple of stars. So even if you forget about revising the information, which I will be talking about a bit later, if you don't have much time for it, then you can just check this box, and I think it will be properly imprinted in your brain. So candida infection, this is a fungal infection. It causes itchiness more, okay? And the discharge here looks like card-like, very thick cottage cheese discharge. It causes inflammation along the vulval area where the pubic hair arises from, and it causes extremely itching. Trichomoniasis vaginalis, it causes offensive, frothy, yellow-green discharge. And on colposcopic examination or PV examination, if you are able to see the cervix, it shows some rosy red spots in the cervix. So this is known as strawberry cervix. Bacterial vaginosis, it's a rather thin whitish gray fishy odor discharge, okay? So look for the term fishy odor. A 24-year-old woman presents to an itchy vulva and pain during sex. She also mentions green offensive vaginal discharge for past 2 weeks. Green offensive vaginal discharge, okay? So what is the most likely diagnosis? No, bacterial is usually
D.
Trichomonas, yes. Trichomonas is the answer. So trichomonas is actually a protozoal infection. It's a sexually transmitted infection, but bacterial vaginosis, remember, bacterial vaginosis and candida infection, these are not STI. Trichomonas is, okay? So feature is vaginal discharge, offensive, yellowish, greenish, frothy. So the color is usually a little bit off, and frothy discharge. It causes irritation, vulvovaginitis, strawberry cervix, pH is more than 4.5. So normal vaginal pH is less than 3.5. It causes alkaline discharge. In men, it's usually asymptomatic, but it can cause urethritis. Investigation is microscopy of a wet mount shows motile trophozoites. So most of the protozoal infection actually shows in the discharge, or maybe, for example, amoeba. Entamoeba histolytica. If you get the stool culture, it will show motile trophozoites, right? So if you go for any other protozoal infection, it usually shows motile trophozoite. Management is oral metronidazole for 5 to 7 days, but you can go for a one-off dose for 2 gram metronidazole. However, the side effect profile will be really high. So patient might be complaining of, diarrhea, loose motion, or maybe not that, constipation, abdominal bloating, vomiting, metallic taste. This will be very much higher with such high dose, which is why you can go for tolerable dose of metronidazole, that is 400 milligram TDS for 7 days. So here again, this picture is showing, like in bacterial vaginosis, there is thin white discharge, and in microscopy, there is evidence of clue cell. And in trichomonas, there is frothy yellow-green discharge, vulvovaginitis, strawberry cervix, wet mouth shows motile trophozoite. And in between this, both of these are commonly seen as offensive, both of these cause offensive discharge. In both this condition, vaginal pH is more than 4.5. And in both this condition, treatment is with metronidazole because bacterial vaginosis is caused by anaerobe and trichomonas is caused by protozoa. So in both this condition, the treatment of choice is metronidazole. Bacterial vaginosis, it's an overgrowth of predominantly anaerobic organism such as Gardnerella vaginalis or Gardnerella mobilincus. It leads to consequent fall in the lactic acid producing aerobic lactobacilli. Lactobacilli is a normal commensal in the vagina. Okay, so the lactobacilli is actually they cause the term itself is lactobacilli, so they can cause lactic acidotic state in the vagina, which is helpful for maintaining the normal pH balance. The bacterial vaginosis is not a sexually transmitted infection, I've already mentioned, and commonly seen exclusively sexually active women. So this is seen among the young women particularly. But do you remember Candida, not an STI, bacterial vaginosis, not an STI, trichomonas is. Here again, the discharge I have already mentioned, fishy offensive vaginal discharge, thin or white gray. So clue cells are present on the microscopy, vaginal pH is more than 4.5 and positive whiff test. So that is if you take the vaginal swab or the discharge, put it on a glass and then add potassium hydroxide in it, it results in fishy odor. This is known as positive whiff test. Treatment is oral metronidazole for 5 to 7 days. And there are certain relapse rate more than 50% within 3 months. Bacterial vaginosis in pregnancy was an increased risk of preterm labor, low birth weight, chorioamnitis, and late miscarriage. It was previously thought that oral metronidazole should be avoided in the first trimester, but now they're saying that using metronidazole is pregnancy safe. So 30-year-old woman presents with white malodorous vaginal discharge. There is no associated H or dyspareunia. Our diagnosis of bacterial vaginosis is suspected. So overgrowth of which of the following organism is most likely to cause the presentation? Lactobacilli, trichomonas, candida, mycoplasma, or Gardnerella? No, the Gardnerella causes depletion of the lactobacilli, which is why lactobacillus is the normal commensal of the vagina. So Gardnerella takes upper hand to cause the bacterial vaginosis. That's why they cause increase the pH. Lactobacilli maintains the normal pH of the vagina. So culprit organism for bacterial vaginosis is Gardnerella vaginalis. Let's pick someone randomly. Let's see, Dr. Gamlath, can you unmute yourself and give me the answer for question number 65?
Okay, sure, madam. A 31-year-old woman presents as she has noted an offensive fishy vaginal discharge. She describes a gray, watery discharge. What is the most likely diagnosis? It's bacterial vaginosis.
Very good. And what's the treatment of choice for bacterial vaginosis?
It's oral metronidazole.
Yes.
400 BD for 5 to 7 days, or clindamycin cream for 7 days.
So oral metronidazole is the first line treatment for bacterial vaginosis. Okay, very good.
Okay.
Okay, let's see. I'll pick another one. Dr. Dipali, can you unmute yourself and read the question 66 and give me the answer?
Yeah, so a 22-year-old female presents with an offensive vaginal discharge. History and examination findings are consistent with the diagnosis of bacterial vaginosis. The most appropriate initial management would be oral metronidazole.
Okay, very good. So thank you. Next topic is urinary tract infection. This is again a very undergraduation topic. Lower urinary tract infection. Can anybody tell me what are the symptoms of lower urinary tract infection and the upper urinary tract infection? What's the anatomical site? Can anybody tell?
Urinary hesitancy will be in the lower rather than in the upper, because upper will give more of pain, like renal or ureteric colics. But cystitis and lower will give urinary hesitancy, burning micturations.
Okay, that's good.
You,
So
yeah,
I will just draw a diagram.
is one of the symptoms.
Yes. So you're very right. Thank you for taking this question. So imagine this is the kidney, and this is the urinary bladder. This is the urethra. And actually, ureter is very long organ in the body, right? So anatomically, the kidney and the pelvic calyceal system, pelvis, and here the ureter begins. So the upper 2/3 of the ureter, this is known as the upper urinary tract, UUT. And the lower 1/3 of the ureter and the bladder and the urethra, this is known as the lower urinary tract, okay? So in case of the upper urinary tract, if there is any infection, stone, or any malignancy or any obstruction, symptoms are a bit non-specific, okay? So usually they present with pain, fever, nausea, vomiting, etc. Pressure symptoms. In case of the lower urinary tract symptoms, urinary complaints are more. Okay. For example, frequency, urgency, dysuria, then post-voidal dribbling, or even nocturia. These are common presentation for lower urinary tract symptoms. So what are the common organisms for urinary tract infection? Can anyone tell me? What are the common organisms?
E. coli.
E. coli.
Yes, E. coli is the commonest one because in female patient, why E. coli is more common?
Close proximity of the vaginal
To the anus. Yes. Yes,
Yes.
very good. Apart from the E. coli, there are certain other organisms that are responsible for urinary tract infection, and these are known as common organisms. So, sorry, Klebsiella, Proteus, these are also common. Pseudomonas. Klebsiella, Proteus, and Pseudomonas, these are common urinary tract infections. Okay. So in order to diagnose urinary tract infection, two important investigations. What are those two important investigations?
Urine FEM.
microscopy and urine
Yes.
culture.
Yes. So urinary, there might be evidence of pus cell, plenty, and then urine culture showing the growth of the organism. And we have to go for the colony count as well. You cannot just check the which culture is the culprit. Sorry, which organism is the culprit, but at the same time in the urine culture report, they mention how many copies are present in per ml of urine sample. That is also very important. And if the if the lower urinary tract infection occurs in two different sites, for example, the urethra is involved, causing the UTI, and there is also evidence of cystitis or bladder infection. So in two anatomical structure, there is evidence of infection. This is known as complicated UTI. If the patient has immunocompromised condition with any one site involvement, for example, only the cystitis is taking place, but the patient is pregnant, for example, or the patient has diabetes, that is also known as complicated UTI, okay? So these are the basics. 7-day course of antibiotic in the UK, the first regimen is given is trimethoprim, nitrofurantoin. Can anyone tell me what's the complication of nitrofurantoin? Some complications of nitrofurantoin?
Lung fibrosis.
Yes. It can cause lower lobe lung fibrosis if taken repeatedly or long-term exposure. All right. So acute pyelonephritis, this is a part of upper urinary tract infection, okay? So hospital admission is very, very important. Local antibiotic guideline, usually the broad spectrum cephalosporin or cefuroxime, these are usually given, or quinolone such as levofloxacin. These type of antibiotics are given for extended period like 10 to 14 days. Okay, so question number 67. Let's see. Dr. Kulsum Alisha, can you unmute yourself and read the question? Give me the answer.
Okay, ma'am. A 25 years old sexually active woman presents with dysuria and urgency. A urine dipstick is positive for glucosides and nitrates. Urine culture and gram staining reveal a gram-positive organism in culture in clusters that is coagulase negative. What is the most likely causative organism? Escherichia coli, Staphylococcus aureus, Staphylococcus saprophyticus, Proteus mirabilis, and Klebsiella. I don't know, sorry.
So if it was not given that gram positive,
Staphylococcus saprophyticus.
Staphylococcus saprophyticus. Staphylococcus, this is a gram positive organism, okay. Culture this coagulase negative, okay,
It's
yeah.
in clusters, no? Clusters, I say, because rods, clusters, and
Clusters are, that means
I
usually
thought-
cocci, right? Yes, you're right. So Staphylococcus saprophyticus is the answer. Because they did not mention directly whether this is a rod or cocci, but they mention it indirectly. Gram positive, so of course the answer will not be E. coli, okay? Unfortunately, E. coli is out of the box. So it's either Staph aureus or saprophyticus or Proteus mirabilis or Klebsiella. But coagulase negative, gram positive organism in clusters, that means these are cocci. So it's either B or C. Staphylococcus aureus is coagulase positive and Staphylococcus saprophyticus is coagulase negative, which is why the answer will be saprophyticus. Okay, very good. Question, not this one. Okay, question number 70. Let's see. Okay, can you read it?
Of prostate cancer, annual surgeries and in long-term catheter inserted a few weeks ago by videos. In ministry, the specimen of urine is positive for spectrum beta lactamidase. He claims he has no dysuria and urine catheter bag looks clear and there are no signs of hematuria. He is also a pregnant and gynecology study.
So basically what they're saying is an 82-year-old man with back pain came to the ward for MRI of his spine, has a background prostate cancer, under surveillance and long-term catheter inserted a few weeks ago by urology. So that's a positive nidus for urinary tract infection. Midstream specimen positive for ESBL, more than 100 colonies. He claims that he has no, so he's basically asymptomatic. Okay, but there are no signs of hematuria. He's afebrile and hemodynamically stable. Sodium, potassium, and urea creatinine is almost normal. CRP is borderline. What will be the next step to manage this bacteria? So the options are, this bacteria should not be treated, ensure good hydration, and monitor any urinary symptoms of pyrexia. Comments nitrofurantoin 100 milligram 4 times daily for 3 days. Comments 1 stat dose of gentamicin IV, and if no response, contact microbiology. Check sensitivities first and commence antibiotic regardless of the clinic, and remove catheter immediately and contact the urology. It's a bit tricky, but let's see. Which one? Option D. You have to go for the check sensitivity first and then commence antibiotic regardless of the clinic. Okay. The clue is actually here that the patient is afebrile, hemodynamically stable, and you have to understand what are the normal commensal in patient who have catheter inserted. Okay. So the answer is this type of bacteria, asymptomatic bacteriuria, should not be treated. Just ensure good hydration and monitor if there is any symptom development or fever, because ESBL can be normally present in catheterized patients. Okay. And you see, like the reason why I mentioned that the number of colony is important. This is not a significant level of colony number in per ml. This is only 100, more than 100 colonies. Usually more than 10 power 2, 10 power 3, 10 power 5, these amounts of organism is required to produce any symptom. ESBL is commonly found in catheterized patients. Okay, thank you for trying though. Okay, next topic is nematode. Actually, not a lot of questions will come from the nematode section. This is actually one-star topic, but sometimes they can give questions from the Strongyloids turcularis particularly. And weird enough, my question actually came from the Ancylostoma brasiliensis. So my question was, which of the following organism is responsible for cutaneous larva migrans? And there were a couple of options, and the one of the option was Ancylostoma brasiliensis, and I went for that. So this is a very cramming sort of question and memorizing topic. So you have to cram the information and you have to memorize it at the right time. Not all the time MRCP part 1 or part 2 will have clinical scenarios. They will sometimes throw in some memorizing questions as well. Okay. This is prevalent in cutaneous larva migrants. It is present in Central and Southern America. Strongyloids turcularis, it's particularly, it is acquired through penetrating wounds, okay? And it can cause, at the site of the entry, it can cause some itching, pruritus, and the larva currents. So larva currents and larva migrants, these are different entities, okay? Be very mindful. Eosinophilia is seen in Strongyloids turcularis. Treatment is with albendazole. Toxocara canis, this is commonly acquired by ingesting eggs from the soil contaminated with dog feces. Commonest cause of visceral. So just put yellow highlighter here, like cutaneous larva migrants. Organism is Ancylostoma brasiliensis. Strongyloids turcularis causes larva currents. And Toxocara canis, it causes visceral larva migrants. Okay. Cutaneous larva migrants treatment is basically thiabendazole or albendazole. So most of the nematodes, they are usually cured by giving albendazole, thiabendazole, these type of anti-helminthic drugs. And what is it called? Not anti-helminthic, anthelminthic or something like that, right? Drugs. Okay. Strongyloids turcularis, just give it again a read. Treatment is combination of ivermectin and albendazole both. And in the here, this is an important information. The larva of the Strongyloids turcularis, after entering through the penetrating skin, can travel along the subcutaneous tissues and enter into the, they can penetrate further into the internal organs, okay? And if the larva migrate to the lungs, a specific type of pneumonitis is triggered. An inflammatory reaction is triggered in response to the Strongyloids larvae. This is known as Loeffler syndrome, okay? Here, there is evidence, in the blood, the eosinophil count will not be that much raised. But if you take a lung biopsy and you put it under microscope, then you'll see plenty of eosinophilia. So this is an eosinophilic pneumonia. So question number 73, a 20-year-old man presented with persistent diarrhea and abdominal bloating after returning from a gap year in Africa, diagnosed as having Strongyloids turcularis. So what were the Strongyloids turcularis organism initially entered the body? Is it sexual transmission, fecal-oral route? Is it penetrated skin, respiratory droplet, or mosquito vector? C, penetrated skin. Okay, good. Tapeworm, not an important topic, but you have to, because it's within the infectious disease, you have to undergo all the topics initially, then you can, plus minus a couple of topics. So tapeworms are basically worms, okay? So segmented, repeated segments, like if I draw a picture, let me show you. So these are, a single section is made up of small segments, okay? This is known as proglottids. So sometimes with the stool, 1 or 2 proglottids will pass in the stool, okay? So this is macroscopical, diagnostic criteria for nematode infection. Sorry, for the tapeworm infection. So there are cystosarcosis and hydatitis. These are most common varieties of tapeworm. So cystosarcosis, this is caused by Tinea solium. It is caused by ingesting pork, and Tinea saginata is caused by eating beef. Management is niclosamide. Okay. And hydatid cyst is caused by dog tapeworm known as Echinococcus granulosa. So humans are the end host and dogs are the definitive host. Okay. So how do humans get affected with hydatid cyst? That's a tricky question. So dog feces, if the dog feces can somehow enter into the person's mouth cavity because of handling of the dog directly, or dog is infected with the tapeworm and the dog stool or parts of the body is gone through the sheep and the humans are handling with the sheep, then this is how the humans can contract this type of hydatid disease. So this is one of the causes of hepatomegaly. It can cause cystic lesion in the liver. So in the CT scan, the fluid will be completely black and there will be a thin rim surrounding the fluid. Life cycle involves dog ingesting hydatid cyst from the sheep liver, often seen among the farmers, okay, animal handlers, may cause liver cyst. Treatment is albendazole. First line treatment in hydatid disease. Okay. Schistosomiasis, there are three types: Schistosomia mansoni, intercalatum, and hematobium. Mansoni and intercalatum causes intestinal schistosomiasis. Look for clues. What are the clues? First of all, look for endemic region. So for schistosomiasis, important are mansoni, intercalatum, and hematobium. Hematobium. So among all this, hematobium is very, very important. Look for clues. Clues are, number one, endemic region. Mainly, for example, DRC, Democratic Republic of Congo, West Africa, Sub-Sahara. Basically, any African countries, schistosomiasis is quite common. Number two is endemic region. Number two is look for if there is any mention of swimming in local pools or ponds, rivers, aqueducts, etc. Number three is there is usually a gap of time. So from the period of traveling, after a few days, 2 weeks, the symptoms will begin, okay? Number four is look for clues like hematuria or frank or gross bleeding. Sometimes even the blood clots can present during the urine. So these are the clues for schistosomiasis. In the X-ray, the schistosomiasis eggs can be present like clusters and they can mimic pseudopapilloma, and over the time it can be calcified. So it can be picked up on the X-ray of the urinary bladder. And you can, so let's see, if this is the urinary bladder, the eggs can be, calcified and give the appearance of pseudopapilloma like this in clusters. All right, hematuria, bladder calcification. Single dose of praziquantel is given in the treatment of schistosoma hematobium. Now, for mansoni and japonicum and intercalatum, they can all cause intestinal schistosomiasis like diarrhea, loose motion, or like abdominal pain, tenderness, hepatomegaly, splenomegaly. They can take place because of the portal vein congestion. Okay. Let's see, 24-year-old, question number 75. I think you'll get it. The answer is praziquantel. It's not that important. Okay, infection with schistosoma hematobium is most strongly associated with, so I have deliberately not mentioned as one complication of schistosoma hematobium. It's undergrad level.
Squamous cell bladder cancer.
Is it squamous or
Transitional.
transitional?
No, it's transitional. Sorry, it's transitional cell bladder cancer.
Okay. So actually, the reason why I told you that I knew that if I tell you whether this is a transitional bladder cancer, you'll go for that. The importance is squamous cell bladder cancer is not that common. For among the bladder cancer, there are several types. Transitional cell bladder cancer is the most common variant, and it takes place at the junction of the bladder to urethra junction because there is a transitional zone. So the lining can get easily replaced, and this is where the area like the neoplastic region begins from. So transitional cell bladder cancer is common normally, but cystosoma hematobium causes squamous cell type bladder cancer. Okay, you can remember it. S for S mnemonic. Cystosoma for squamous cell bladder cancer.
That means I was correct.
Okay, you are right, but I wanted to make you confused, so you fell into my trap. Okay, so question 77, 34-year-old man. A 34-year-old man from Zimbabwe, so that's the endemic zone, admitted with abdominal pain on the emergency department. An abdominal X-ray reveals urinary bladder calcification. What's the most likely cause? This is very easy. Hematobium. Very good. Where is Mallory and Kalazar? Okay. Malaria থেকে দাঁড়ায় পড়বো হ্যাঁ আরেকটা টপিক আছে So this one is the trypanosoma brucei and cruzi Chagas disease. This is actually 3-star topic. Sometimes true false statements can become from the part 1 and part 2. Two main forms of this protozoal disease are recognized. One is the African one and the American one. The African trypanosomiasis is known as sleeping sickness, and the American trypanosomiasis is known as Chagas disease. Two forms are present. Again, this is caused by CC fly. This is the vector for trypanosomiasis. Okay. Trypanosomiasis rhodesians tends to follow a more acute course. Clinical features are this is rhodesians and causes African trypanosomiasis basically. Okay. So it can cause chancre, that is painless subcutaneous nodule at the site of infection, intermittent fever, lymphadenopathy. Later, CNS symptom can be involved like somnolence, headache, mood changes, and meningoencephalitis. So this is the African variety. The African variety or the African trypanosomiasis is caused by the organism Trypanosoma rhodesians. Okay. So look for clues like somnolence, CNS symptom, basically somnolence, headache, mood change, meningoencephalitis. In early disease, IV pentamidine or suramine is given. In later disease or when the CNS system is involved, then melarsoprol is given. In American trypanosomiasis of the Chagas disease, mainly two organs are involved in the later stage. Without going through it, can anyone tell what are the two organs that are commonly involved in the late stage of the Chagas disease or the American trypanosomiasis?
Esophagus.
Esophagus, yes, very good. The heart becomes big and the food pipe becomes big, okay? These are two complications related to Chagas disease, mega esophagus and cardiomegaly, okay? Caused by a protozoa called Trypanosoma cruzi. So rhodesians was previously known as brucei. Trypanosoma brucei, that is currently known as rhodesians, and Trypanosoma cruzi name is not changed. The vast majority of the patients are asymptomatic in acute phase, although chagoma, which is an erythematous nodule at the site of infection, can be present in periorbital edema, sometimes seen. Chronic Chagas disease mainly affects the heart and the GI tract. So myocarditis may lead to heart failure and arrhythmia, and gastrointestinal features include megaesophagus and megacolon, causing dysphagia and constipation. Treatment is most effective in the acute phase using azole or nitro derivatives. Chronic disease management involves treating the complications such as heart failure. So if you put these informations to side by side, one is African, American, Trypanosoma rhodesians. This is cruzi. All right. Then in African, fever, lymph nodes, malaise, plus CNS feature. That is somnolence, headache, mood changes, meningoencephalitis. These are commonly seen. In American variety, heart plus GI tract. These are commonly involved. And in the acute phase, there are no symptoms. So in the heart, it can cause dilated cardiomyopathy or cardiomyopathy leading to heart failure or arrhythmia. And in the GIT, it can cause megaesophagus or megacolon. All right. And in the African trypanosomiasis, both trypanosomiasis vector is CC fly. In both this condition, at the site of infection, there might be some nodular papule or chagoma. This is common for both these cases. Treatment for African trypanosomiasis is basically IV pentamidine or suramine. And in late cases or in CNS manifestation, melarsoprolol is given. And in case of the American trypanosomiasis, treatment is usually azole or nitroderivatives. And treatment of the complication. Just remember it, like make a box side by side and then write down the differences. I think that will help you more. So following a recent holiday to South America, 19-year-old woman returns home and within a month develops swelling around the right cheek with increased fatigue and diarrhea. Diagnostic thick and thin film blood identified the parasite Trypanosoma cruzi. Cruzi is for American trypanosomiasis. So which medication can be used to treat her condition during the acute phase of the disease? Azole. Look for the word azole. Benznidazole is the answer, okay? So azole groups and nitroderivatives, these are used for the treatment of trypanosomiasis, American variant. Okay, what about this one? Diagnosis of Chagas disease is confirmed. What is the most appropriate treatment? Again? Benznidazole. Yes, good. 37-year-old immigrant from Bolivia admitted to the emergency department following a collapse. He is known to have a history of Chagas disease. See, compared to sleeping sickness, Chagas disease is more highlighted. Which one of the following complications of Chagas disease accounts for the majority of mortality in affected patients? So is it myocarditis, large bowel perforation, perinephric abscess, meningoencephalitis, pulmonary hemorrhage? Which one?
Or A, myocarditis.
Myocarditis, yes, good. You won't be able to believe that the medical officer is asking for the treatment of acute gastroenteritis. Okay, so now I will take the further, I think I have 3 more topics to go through: malaria, Kala-Azar, and toxoplasmosis. And I will take these classes standing, okay? Just give me a minute. Within the neglected tropical disease or NTD, okay? So these are particularly common for countries like Bangladesh, India, Pakistan, in the African regions. So in the tropical countries, these diseases used to be neglected and underdiagnosed. This is why they are broadly termed as NTD. It's actually a very interesting topic, and NTDs are they are getting lots of recognition and funding nowadays. So if any one of you is interested to pursue a clinical master's or maybe PhD later on, then this is an important or maybe an interesting field that you can work on. There are so many fundings available, so it's easy to get scholarship in these fields. So malaria, falciparum malaria is the most common variant. There are other variants like Plasmodium vivax, Plasmodium ovale, but among these ones, malaria, Plasmodium falciparum is the most common one because it can cause cerebral malaria. Okay, so what are the features of severe malaria? You have to like remember them. So one of these are Saigens, presence of Saigon on the blood film. Parasitemia if the count is more than 2%. If there is evidence of hypoglycemia, there is evidence of severe anemia. Temperature is more than 39 degrees Celsius. And complications such as, for example, cerebral malaria, acute renal failure, which is known as the black water fever. And this acute renal failure actually takes place because of hemolysis, okay? Intravascular hemolysis. And this, sure. Okay, so intravascular hemolysis can lead to formation of hemoglobinuria, hemosidenuria, and they will pass through the urine, thereby making it very dark in color, which is why this is known as black water fever. And acute respiratory distress syndrome, so these are basically organ involvement. Acute respiratory distress syndrome is non-cardiogenic pulmonary edema, which can be a complication of the falciparum malaria. Sepsis or septicemic shock, these are also some complications. Where did you go? So, like the complications, acute renal failure, cerebral malaria, acute respiratory distress syndrome. And disseminated intravascular coagulation or hypoglycemia and sepsis, septic shock, these are all complications related to Plasmodium falciparum. So these are the markers for severe malaria. And they might give you information like which one of the following is not a marker of severe malaria. And they might tell you like temperature 38.7 degrees Celsius. Or they might give you clues like parasite count or parasitemia is 1.8%. So that is below 2%. So it will not be a marker of severe. And absence of Saigens in the blood film. Okay, so look for clues like that. Of course, with complication, it will be easy to pick that up. You will not readily miss that complication part as a marker of severity. But it's easy to mess up the numbers. So be very vigilant in terms of remembering that. So in case of the uncomplicated falciparum malaria, what is the treatment? Remember, for any malaria, main treatment for focused on the ACT base, that is the তো লেখা যাবে না তো এটা দিয়ে এটা দিয়ে হবে আচ্ছা ঠিক আছে রাখেন তাহলে আচ্ছা ঠিক আছে So, okay, for treatment of uncomplicated falciparum malaria, this is ACT treatment, which is known as the artemether or artesunate based treatment. So it's usually in the combination of, as you can see, artemether plus lumefantrine, artesunate plus amlodipine, artesunate plus mefloquine, blah, blah, blah. Look for the clues like artesunate or artemether. Okay, this will probably not come in the exam anyway. And next up is the severe falciparum malaria. So usually in severe falciparum malaria, that is, we think about the cerebral falciparum malaria, okay? Usually patient comes with the features of meningitis or unconscious patient or disoriented patient. In that case, IV treatment is mandatory. IV treatment is, previously we used to give IV quinine, but nowadays they are saying that IV artesunate is now superior to the IV quinine, okay? And parenteral treatment is given if the parasite count is more than 10%. So this is very high amount. Then in that case, we have to change the blood. We have to completely change the blood for a healthy blood. This is known as the exchange transfusion. And shock may indicate there is coexistent bacterial septicemia because malaria itself does not cause any hemodynamic shock. So for example, if the malaria and the parasite count is very much high, more than 10%, and there is lots of or multi-organ failure going on, and there is introduction of the secondary bacteria, okay? That's when the patient will develop subsequent hypovolemic or septic shock. So let's see, question number 83. It's a very good thing that in MRCP part 1 and part 2, because malaria is a neglected tropical disease, and it's a very highly specialized topic of discussion for UK especially, which is why they are not really interested to know about the dose calculation. But in our country, I remember that in 5th year, we had to give lots of significant amount of importance in the treatment of cerebral malaria, the doses and the complication of quinine and everything. But for part 1 examination is not that required, but try to look for clues like if there is any mention of artesunate or artemether, that's your answer, okay? All right. 32-year-old oil worker presents by the ambulance to the emergency department following his return from Angola. His wife reports that over the past 24 hours, patient has become progressively more drowsy with fever ongoing for the past 5 days. On examination, the patient is unresponsive to the voice and is visibly clammy. His observations are heart rate is increased, that is 120 beats per minute. Blood pressure is a bit low, 100/60. Respiratory rate is increased. There is tachypnea. SpO2 is normal. And initial investigation is showing that there is hemoglobin is significantly low. And platelet count is, there is evidence of thrombocytopenia. WBC count is raised. So there is anemia, thrombocytopenia, and then there is neutrophilia. Sodium count is normal. Potassium count is slightly on the high end. So there might be chances of developing acute kidney injury. Urea is borderline. Okay. Creatinine is 190. It is definitely raised. Bilirubin is 70, normal. Malaria film is showing Plasmodium falciparum species, 12% parasitemia. Okay, that is your clue. Now, given that the patient's condition, what treatment should be commenced?
Option C.
B.
Yes, very good.
B.
Because artesunate is the answer and more than 10% parasitemia. In that case, we have to go for the exchange transfusion. Okay, very good. All right, next up is, I think these are just some of the complications, criteria for severe, I have already mentioned that. So question number 86. A 24-year-old man is admitted to the emergency department with breathing difficulty and confusion 3 weeks after returning from a holiday in Cambodia. His partner says that he has had the flu for past 2 weeks. A blood film is positive for malarial parasite, and a chest X-ray and arterial blood gas suggest acute respiratory distress syndrome. So this is a complicated Plasmodium falciparum. A diagnosis of severe falciparum malaria is suspected. What is the treatment of choice? Sorry, I already showed the answer. Anyway, go on. What is the treatment of choice? So I think most of you are thinking whether this is a case of IV artesunate or IV artemether and lumefantrine, right? Because you are in between these two options. So theoretically, either of these two options would be correct, but actually in uncomplicated falciparum malaria, this combination regimen is used. Rather, in complicated malaria, the only single artesunate or artemether based treatment is given. So that's why the answer is IV artesunate. So what are the other non-falciparum malaria? So there is, okay, let's see. So you can see that Plasmodium vivax and Plasmodium ovale, these are two important ones. Plasmodium malariae is a bit rare, okay? But it can sometimes be present as well. Plasmodium knowlesi is a clinical pathology, but this is a very rare type. So important one is the vivax and the ovale. General features for malaria such as fever, headache, splenomegaly, these are all common in the non-falciparum malaria. And for the vivax and ovale, there is usually fever comes on every 3rd day. In the malaria, the fever comes on every 4th day. That is every 72 hours. Plasmodium malariae is associated with nephrotic syndrome. Which nephrotic glomerulonephritis it causes? Write it down, membranous. Membranous glomerulonephritis, okay? Plasmodium malaria can cause membranous glomerulonephritis, thereby leading to nephrotic range proteinuria. For now, remember this information when you're going through nephrology, then you'll be able to correlate this information altogether. So treatment of Vivex and Mallory, this is actually chloroquine, this is actually dependent on whether these strains are chloroquine sensitive or these are chloroquine resistant. In both cases, actually, our ACT treatment is preferred. In case of chloroquine sensitive, apart from the ACT, you can give chloroquine. But in case of the chloroquine resistant, there is no role of chloroquine. So you have to go for the ACT-based treatment. ACT is a teratogenic drug. Remember that. So you cannot prescribe it in pregnant women. Patients with Vivex or Ovally, they are actually given primaquine. Why? Because Vivex and Ovally, they can cause liver, they can produce hypnozoite. This is a latent, forms of malaria that can present or hibernate within the liver for a very long time, and that's when the malaria can relapse. So in order to prevent that from happening, in order to destroy the hypnozoite, you have to give additional coverage. That is, you can do it by giving a primaquine, okay? So after giving the ACT-based treatment or the chloroquine for the Vivex and the Ovally, in order to get rid of the hypnozoite, you have to combine the primaquine. Okay. So let's see question number 89. A patient who has recently returned from the Ivory Coast presents with cyclical fever and headache, found to have splenomegaly on examination. Following a blood film, he is diagnosed as having Plasmodium vivax malaria. He is treated initially with chloroquine, then later given primaquine. What is the benefit of primaquine? Destroy liver hypnocytes and prevent relapse. Very good. Okay, a 23-year-old student returns from India, develops febrile illness. Following investigation, he is diagnosed as having Plasmodium vivax malaria. This area is known to harbor chloroquine-resistant strain. So what is the most appropriate initial management to treat the acute infection? Which one is the answer? Primaquine, okay. Initially, do you give the primaquine? Initial management. So that's for the hypnozoites.
I think so it's B or E. B or E.
Okay, B or E. Atorvaquone and proguanil is actually used as chemoprophylaxis, okay? So for prophylactic measures. So what should be your answer? This is chloroquine resistant, right? So you cannot give chloroquine. So if you can't give chloroquine, what is the treatment you give? Look for the option ACT.
E.
So ACT contains is the E, option E, artemether and lumefantrine, okay? All right. So malaria investigation, we all know that malaria investigation can be done with, let's see. So thick film and thin film, these are more important. And thick film is for the more sensitive because it can identify the family and the genus. And thin film can identify the species. So this is more specific. Sensitive one is the thick film and thin film is for more specific. Other tests that can give you conclusive idea, that is thrombocythemia, thrombocytopenia. This can be, you can see, hemolytic anemia can be present, normal WBC count, and reticulocyte can be high. And here, as one of the information is, apart from the thick and thin film, RDT test, which is a point of care based test. For example, thick film, thin film takes longer preparation time, requires lab facilities and all that. But RDT test or the rapid diagnostic test, it's a kit, okay? So taking a sample from the body, like if you take a small amount of blood and put it on the RDT kit, it will show like double line, in like similar to a pregnancy kit, okay? So this can be used commonly in endemic area at the point of entrance. All right, let's see. 35-year-old man who has recently immigrated from Zimbabwe to the UK presents to the emergency department with fever, myalgia, and headache. He is suspected to have malaria, which test is most likely to allow for the accurate specification of the malarial pathogen. What's your answer? Is it
B, thin blood film will give you the pathogen and thick blood film will confirm the diagnosis of malaria.
okay? So what's your answer?
My answer is B, I don't know.
Okay. Yes, this is your answer, thin blood film, because they want to know the accurate speciation. That means they want to know about the species of the malarial pathogen. So in order to check the species, you have to go for the thin blood film, right? And point of malarial test is not done to check the species. It's actually done to detect the malaria, like whether the patient has malaria or not. That's all. So malarial profile exists. There are lots of information given, like if you're traveling to an endemic area, then you have to take the profile exist. Most of the profile exist starts 1 week before, and then you have to continue it for 4 more weeks after coming back from the trip. So there are different types of combination. One of the traditional combination was the atovacon and proguanil, which is known as the Malaron. All you have to do is like know about the combination, like what are the available prescription for chemoprophylaxis, and what are the common side effects, okay? Nothing else. So Malaron usually causes GIT upset. Chloroquine, you cannot give chloroquine and mefloquine to patients who are having epilepsy because they can cause some neuropsychiatric disturbance. And doxycycline causes photosensitivity, skin rash, and esophagitis. So doxycycline is also teratogenic, so you have to be mindful regarding that. Proguanil usually is not that effective and it's not commonly used anyway. It has a less side effect profile. Proguanil plus chloroquine will show side effects related to chloroquine, okay? So I'm mentioning again, Malaron causing GIT upset. Chloroquine, mefloquine, you cannot give them in epileptic patients. And proguanil single-handedly does not have any side effect, but if given with chloroquine, it will have side effect related to chloroquine. And doxycycline is teratogenic and it causes esophagitis and photosensitive skin rash. So among all this chemoprophylactic medication, which one drug I have mentioned that you cannot give to pregnant women? Doxycycline, very good. Because all the other chemoprophylaxis can be given sometimes considering the risk-benefit ratio. But you can never ever give doxycycline in a pregnant woman.
Madam, you said earlier chloroquine also contraindicated in pregnancy, isn't it?
Chloroquine, yes. Actually, they are not, there haven't been any large studies, available. But if the information, like if the option gives like which is absolutely contraindicated in pregnancy, and the option says separately chloroquine and doxycycline, then my suggestion is go for doxycycline, okay? So compared to chloroquine, doxycycline is more teratogenic. That's what I'm trying to say.
Madam, excuse me. Hydroxychloroquine is given for rheumatoid during pregnancy, no? Is it hydroxy?
Yes, but that's given for rheumatological purpose, right? So in pregnancy, if a patient has rheumatoid arthritis and if the patient's symptom is controlled, well controlled with hydroxychloroquine, then considering the risk-benefit ratio, you always have to like form a multidisciplinary team, including the women health specialist and the rheumatologist, and take their decision. And if possible, go for the maintenance dose at the lowest possible dose so that it does not cause any, significant teratogenic effect. And on top of that, the gynecologist will probably say that if possible, during this first and second trimester, instead of giving hydroxychloroquine, give the patient steroid, because steroid is not contraindicated in pregnancy. But when organogenesis takes place, then they switch back to the low dose hydroxychloroquine at a maintenance dose. So this is actually a combined, thinking process. It's not a single physician's decision. But what I'm trying to say is, among all the chemoprophylaxis, doxycycline is always, always, always contraindicated. If the option says that which of the following is pregnancy contraindicated, and chloroquine, mefloquine, proguanil, doxycycline, artesunate is given, then among all these medication, your answer should be doxycycline. Okay, so in children who are like, pregnant women, they're advised not to travel to the malaria endemic zone. However, if they do, if this is a must, then there are 2 medications that can be given to children. One medication is the DEET, that is diethyltoluamide. It can be given in children who are more than 2 months of age. But a bit older children, more than 12 years of age, you can give doxycycline, but it should not be given to children less than 12 years of age, because it can cause significant enamel abnormalities and dental abnormalities and bony problems as well. Okay. So for leishmaniasis, divided into three categories. One is cutaneous leishmaniasis, the other one is mucocutaneous leishmaniasis, and the final one is visceral leishmaniasis. So for cutaneous leishmaniasis, this is go for the commonest organism, that is Tropica majora and mexicana. These are the common causative organism for cutaneous leishmaniasis. And at the site of bite, the vector is sandfly. Okay, this is commonly seen in patients who live in muddy or home that are made up of soil or clay. And cutaneous leishmaniasis, crusted lesion at the site of the bite, it usually looks like honey crusted lesion or golden hue. The pus color is golden or honey-like. And when the crusting falls off, then there is an undermined ulcer formation. Mucocutaneous leishmaniasis is caused by Leishmania brasiliensis. So here, if you remember, one Mexicana causes cutaneous, mucocutaneous is caused by brasiliensis. Okay, skin lesions may spread to involve the mucosa of the nose, pharynx, and the larynx, and the lips and the gums as well. Visceral leishmaniasis, this is our topic of discussion. It is caused by Leishmania donovani, and this is seen among the Mediterranean, Asian, and the African regions. Fever, high-grade fever with chills and rigor, and there is usually slate gray appearance in the skin, which is why it is known as Kala Azor. And there is evidence of huge hepatomegaly or huge splenomegaly. And there is usually poor appetite, loss of weight, and sometimes calf epistaxis. This can also present because of hypersplenism. All the cell counts can be low. So when all cell counts get low, because of anemia, patient will complain of fatigue, tiredness, shortness of breath. Because of low WBC count, patient will have intracurrent infection. And because of thrombocytopenia, patient will have bleeding spots or epistaxis from the body. Pancytopenia, it's a complication secondary to hypersplenism. So how do you detect a case of Kala Azor? So first of all, there are some serological tests, and you can go for the biopsy and histopathology. And among the serological tests, the commonly used serological test is RK39 rapid antigen test. It's a latest agglutination test, latex agglutination. Okay, I think, where is it? So actually, you can go for the antibody level test, antigen test, and a biopsy histopathology. So here you can see the biopsy histopathology. This is the confirmatory or the gold standard. This can be taken from 3 different sites. If there is lymphadenopathy, you can take the lymph node specimen. If there's splenomegaly, you can take the splenic aspiration. You can also take the bone marrow, because Leishmania donovani bodies are present in the bone marrow as well. They invade the bone marrow. So you can go for either of these 3 specimens. And you can go for the antibody detection, either the IFA test, indirect fluorescence antibody, or the ELISA test. And most commonly used is RK39-based immunochromatography test, or ICT. Serology limitations are, after treatment, they can be positive for years. So they do not show whether there is any recurrence or relapse. Tests are positive in many patients who do not have visceral leishmaniasis at all. And serology may be negative if the patient is severely immunocompromised, which can be seen in positive HIV infection. So serology test has its own certain limitations. Antigen detection, this can be done by latex agglutination. And for the treatment for visceral leishmaniasis, treatment is liposomal amphotericin B or miltefosine. No need to go for the dose separately. And prevention is important, sandfly control. And PKDL, this is a post-leishmaniasis complication known as post-Kala Azor dermal leishmaniasis. Years after successful treatment, it can take place, and the lesions kind of resemble like leprosy. Okay. So this is rather not an infectious reaction. This is rather inflammatory reaction. After you treat the patient, years after treatment, it can take place. And if you go for the antigen antibody, it will be negative. So there is no active Kala Azor, but the patient has some dermal lesion that is resembling like leprosy. This is known as the post-Kala Azor leishmaniasis. So 23-year-old soldier who returned from a tour of Afghanistan 2 months ago, presents with a large painless ulcer on the back of his hand. He reports that it started as a small papule, gradually enlarged. On examination, he has a 3-centimeter ulcer with central depression and a raised indurated border. He's otherwise well in himself and no other medical problem. So in the hand, there is a painless ulcer returning from Afghanistan. So what is the likely cause? Is it cutaneous leishmaniasis, sarcoidosis, primary syphilis, pyoderma gangrenosum, or Buruli ulcer? Actually, for sarcoidosis, there should be other systemic manifestation. For example, shortness of breath because of the pulmonary infiltrate or bilateral hyaline lymphadenopathy. There should be evidence of erythema nodosum in the legs, shin of the legs. There should be mention of joint pain, skin rashes. So nothing is mentioned, only skin rash. Single skin rash is present. And the site is not that specific for pyoderma gangrenosum. Patient has no background rheumatoid arthritis or inflammatory bowel disease, so it will not be the answer. Syphilis will cause genital ulcer, so this is not the answer either. So the only option is a tropical area or the endemic area, and a single painless ulcer on the back of the hand is very much suggestive of cutaneous leishmaniasis, okay? Part of Asia.
Madam, can you explain about Buruli ulcer as well?
I'm not
Option
even
E.
sure what is Buruli ulcer. I don't know. I don't know what Buruli ulcer is. Sometimes they will give you options like that, and it's highly unlikely that the answer will be Buruli ulcer. I am not sure whether they have given any information on the explanation part. Travel history, pyoderma gangrenosum, you would expect to be painful. More acutely, Buruli ulcer is an ulcer caused by Mycobacterium ulcerans and can present like this, but it's very rare, usually found in children, and has not been reported in the Middle East. So that's all I know, and this is how the information is provided. This type of atypical answer is highly unlikely to be the right answer in MRCP Part 1. So even if I didn't know what Buruli ulcer is, I immediately knew that the answer will not be the option E. Okay. All right, question number 95. No, not this one. Yes, question number 96. It actually came in, I think, 2021 first diet. 25-year-old man returns from a gap year in Central and South America, presents with a 2-month history of an ulcerating lesion on the lower lip. Okay. Examination of his nasal and oral mucosa reveals widespread involvement. So what is the likely cause? First of all, this is a case of mucocutaneous leishmaniasis, right? So mucocutaneous leishmaniasis, what is the likely cause?
Braziliensis.
Braziliensis, good. Giardiasis, I have already mentioned that it causes chronic diarrhea, usually non-bloody. It can lead to chronic diarrhea in the small bowel. It can lead to malabsorption. So giardiasis patient can present with tiredness, fatigue, vitamin D deficiency, osteoporosis, proximal myopathy, this type of malabsorption related complication, bloating, abdominal pain, long-standing chronic diarrhea that is not responding to traditional antibiotic, that is another clue. And giardiasis is one of the common organisms that can invade in the colon of diabetic patient, okay, immunocompromised patients. Stool microscopy for trophozoitic cysts are classically negative. So that's why you have to take the duodenal aspirate by using a string. So that's why this is known as string test. Treatment is with metronidazole. It's a protozoal infection. Last topic for today. Even I'm exhausted after giving such a big lecture. So that is toxoplasmosis. This is a protozoa. Toxoplasmosis gondii infection. Will it be symptomatic in normal individual? Yes or no? The answer is no. Toxoplasma gondii, it gets transmitted from cat feces, okay? So, for example, if a human who is immunocompromised has a cat and the cat is infected with toxoplasmosis gondii, and then the oocyst releases the trophozoites, and that's when somehow it gets from the handling into the immunocompromised person's body system. Then that's when it will cause symptoms, okay? Commonly seen in HIV patients whose CD4 count is less than 200 cells per millimeter cube. So most infections are asymptomatic. Symptomatic patients usually have a self-limiting infection, often having clinical feature resembling infections of mononucleosis like fever, malaise, lymphadenopathy. These will be present. And cerebral toxoplasmosis, on the other hand, it causes some ring enhancing lesion. I mean, ওই patient যেতেই পারলাম না. Okay. So in immunocompromised patient, imagine this is a CT scan. Okay. So there are multiple ring enhancing lesion. Okay. They look like this, kind of like cavitating lesion. So this is characteristic for toxoplasmosis. Okay. This will be broadly discussed in the CNS or the neurology section. So there are different CNS manifestation for HIV infected patients. So toxoplasmosis is one of the opportunistic infection that can take place. All right, so investigation is you have to go for the antibody test and the Sabin-Feldman dye test. This is not nowadays done. You can just go for the ELISA antibody test. Treatment is usually reserved for those with immunocompromised or severe infection. In that case, you can go for the pyrimethamine plus sulfadiazine or cotrimoxazole treatment, basically, for at least 4 to 6 weeks. Congenital toxoplasmosis, it takes place during second trimester, particularly first to second trimester, particularly through transplacental spread from the mother to the fetus. It causes a variety of defects to the unborn child, including all the CNS complications, that is microcephaly, anencephaly, hydrocephalus, cerebral calcification, and in the back of the eye, it can cause some pigmentation deposition, which is manifested by choroidal retinitis. So which one of the following statement regarding toxoplasmosis is true? Is it a type of flagellate? Congenital toxoplasmosis results in optic nerve atrophy. Ceftriaxone should be used initially in patients with HIV-associated toxoplasmosis. Cat is the only known animal reservoir. Infection is usually self-limiting. Which one is the true answer? Yes, because most of the time, healthy individuals, infection is self-limiting. This is not a flagellate. This is actually a protozoa. Congenital toxoplasmosis results in micro or choroidal retinitis, not the optic nerve atrophy. Treatment should be pyrimethamine and sulfadiazine. And cat is not the only animal reservoir. It's a common reservoir, not the only reservoir. Rats are also known to be the reservoir for toxoplasmosis. Infection in healthy individual is usually self-limiting. Okay, question 99. This is the last question. So anyone from the online is more than welcome to answer this. A 29-year-old HIV positive man is admitted with right-sided hemiplegia. For the past 4 days, he has been complaining of headache and flu-like symptom. CT scan shows multiple ring-enhancing lesion. A diagnosis of cerebral toxoplasmosis is suspected. What is the most suitable management? So this is not the answer because it's a malarial management. So your options are cotrimoxazole supportive, okay, pyrimethamine and sulfadiazine. Okay, fine. The answer is pyrimethamine and sulfadiazine. Okay, that's all. Thank you so much for the patient's hearing. If you have any questions from today's discussed topic, then you can ask me.
Ma'am, I do have questions.
Okay.
I have two questions about exam preparation.
Yes, go on.
Okay. First one is, where do we find past paper questions?
Okay, so what's your first question?
Where do we find past paper questions?
She's asking about the previous exam question papers.
Oh, these are confidential, so you can never get them anywhere. But sometimes in the Facebook groups or in the social media groups, what happens is after giving an exam, some candidates will discuss some recalls. And from the recalls, some similar questions are arranged in different question banks. So if you go through all the question banks, you will be, solving these recalls anyway. So there is no single or separate way you can get this question from anywhere. These are confidential. And if the RCP comes to know about this, that these questions are widely being, used, or if they can pin it on a certain individual, then they can actually take your RCP number. Any other question?
Okay. Every system, there is question bank other than past medicine and past testing. What are those questions?
No, you just need to go through the past test and past medicine. No other question bank is actually needed. If you go through our lecture and if you manage to go system wise, if you're done with the question bank that we provide, And then if you solve past medicine and past test, actually for part 1, definitely no other resources actually required.
Okay,
There,
thank you.
sorry?
Thank you, ma'am.
Okay, you're welcome. Any other question?
Ma'am, I have applied for the August diet and I
August
wanted to
diet.
know till when, yes, ma'am, wanted to know till when can we, finish all the topics and everything.
So you're preparing to give the exam in August, right?
Yes, ma'am.
Okay, and what's your question?
Ma'am, I wanted to ask when will the entire portion be completed by in Doctor's Academy, the online lectures and everything.
That I'm not sure, because the way we are assigned with the classes, it actually takes place according to the block and the system. So I'm not sure at which system, because a lot of candidates will join our class from the middle path or from the very beginning or towards the end. So I'm not sure, like maybe the administrative team can give you the answer. Okay. Like they
All
can
right,
check your
ma'am.
records and they can see like from where you have started the class, and they can give you the expected date for our lectures to end. Okay.
Yes, ma'am. Thank you.
All right. You're welcome. So if you don't have any other question, then I would like to end today's
Excuse me
discussion.
from Sri
And
Lanka. I am from Sri Lanka, madam. Excuse me for a minute. Madam, for in our area where the leptospirosis is quite common,
Mhm.
people are given, farmers are given prophylactic doxycycline once a week. Like, is it helpful or is this a rational practice?
So for preventive measure, do you mean doxycycline is being given?
Yeah.
Actually, doxycycline does not have any immunomodulating effects. So as chemo profile exists, I don't think that it has any other added benefit. Rather, there is increased chance of antimicrobial resistance in that area. So I have not personally read about any guideline like that. Maybe you can check this with your local authority. Maybe they can give you some proper explanation. Even though leptospirosis, if it's an endemic area and there are lots of cases prevalent going on, but still there is no justification of treating patients prior to developing this infection. You have to contract this spirochete and then you can treat this infection. You cannot prevent it. This is not some sort of virus that you can prevent. Okay.
Madam, thank you very much.
Okay, you're welcome. So I'm ending today's discussion then. Thank you all, and I hope to see you after Eid. So Eid Mubarak to you all, and hope that you enjoy the remaining of our discussion and the study. Thank you. Bye.
Eid Mubarak to you also, ma'am. Take care.
Thank
Thank you.
you. You too.